Joe, did you sign? Close colleague. And that night, hey, here's a wonderful lab.
Well, I would lock the door. Yes, yes, this is true. Yeah.
So I promised him I would ask.
Okay, yeah, thank you.
We're just call me when I'm on the plane yesterday.
Oh,
I would love
all right.
Did you sign in, Jürgen?
Maybe not here, downstairs. Yes.
Yes.
I do it here.
Well, I have a lot of tension before the conference. After that, I'm much
Christine's computer? Will it? It's sheeping on.
We are live.
We're live.
We are live. Ladies and gentlemen, we're streaming live right now. Just be advised, don't do too much of this.
Is this the camera right here?
Yes.
Okay, welcome. Welcome to IHLA in Geneva.
Wait a minute. Someone messed with my camera.
Will you now move it to the because it's on the website thing?
Yes. I'll go flip. Flip. All right.
Okay.
So who's first? You're first? You're first. Why
Maybe
is
I'm
going
first.
video is all fuzzy? What is up with this?
I'm on the third.
Third? Okay. All right. I'll just have to remember third.
Well, shall I'll come and give it you.
Okay, you do that. Yeah, that'll do.
Anyway, I will,
Yeah, no.
do this from here.
And yours, Jürgen, yours
Second.
second. Okay.
Session 1, yeah?
Okay.
Session
All
1.
right. I got you.
Most of the resources.
Gotcha. No problem. I'll have to flip back and forth every year.
Yeah.
But, they're 20 years old. But I think you'll find it when you leave home. And then let me know if they are helpful or they're not. Either way.
Thank you.
Doesn't matter. We'll be happy.
Thank you.
We tried to translate.
So you tried to translate?
Medlineplus.gov. If you've never seen it, take a look. Medlineplus.gov is
Oh.
patients and public to learn about health. It's huge. That's the highest rated website in the United States. Most credible. I do not, we don't have the list, but I'll write it down. I guarantee you, it's in your handwriting. Robert Logan, O-G-A-N. Easiest way to reach me is L-O-G lowercase, R-O-B @gmail.com. That's the easiest way. I can give you my information, but it's Cleveland's Club at gmail.com. I'll write this one.
Could I ask the folks to stop walking in front of the video? Thank you. Because the camera's freaking out over here.
Okay.
Okay?
Very good.
Thank you. Can I, one more time, say, please stop? Just stay one place. Thank you.
There we go.
Yes.
We are on
Okay.
So,
Starting.
now your time?
Paper?
You have time now?
Yes, sure. I
Some people will continue.
don't
Yes,
have time to
yes,
do
yes,
this.
yes.
Then flip back over. She started. And she'll want to show the website. I can copy your slides over if you want.
Yeah, but you just I just need it when I need it.
It'll be up there.
Okay, and find the right thing.
Got it.
Pelican Geneva.
Got it.
Click on this.
So we are on.
You are looking at the information about everyone. And I can click on something else and we have all of the literature that's published.
Good as we can go right now. Okay. Okay.
So, good morning, everyone, and welcome to Geneva, and welcome here in the Federation of Public Health, World Federation of Public Health Associations. Let us introduce ourselves.
So I am Antoine Flau. I am a medical doctor and epidemiologist, and I am the professor of global health at the University of Geneva, chairing this Institute of Global Health, and we are very, very happy to welcome all of you, and very proud also that you have chosen this institute and Geneva as a location for your first global meeting on health literacy. I think it's absolutely crucial and key to foster this momentum and to help as much as we can. And we have a long tradition of hosting the World Federation of Public Health Association, thanks to Bettina Borisch. Unfortunately, she could not attend, and I have also to leave to Berlin because I will chair the World Health Summit this year.
Yes.
And I apologize because I will be at the beginning of your discussions, but I could not attend to the whole meeting, unfortunately, because I know, thanks to Peter, who often involve me in this road, I know a little bit about your movement, and I think it's quite important.
We hope you will bring it to the World Health Forum in Berlin.
Yes,
and
yes,
the
yes,
message
yes,
from
Peter
this
will
meeting.
will come.
Very
Yes.
welcome.
Yes, and I think we will try to push as much as possible this important problematic. Yeah.
I'm Peter Chang. I'm professor in Taipei Medical University and Kaohsiung Medical University, two universities. And I'm one of the founder and initiator for the Asian Health Literacy Association, 2014. And we are very fortunate to install in Geneva from Asia, and I'm very pleased to join you together here to see this historic moment, to have a new health literacy federation.
Sabrina Kurtz-Rossi, an assistant professor at Tufts University School of Medicine. Thank you for joining us, and thank you online for joining us, and thank you for having me here today. This is very exciting to be in Geneva. I'm very excited to be in Geneva, and for us to be, for me personally, to be partnering with Christine and Peter to get momentum and move this vision of an International Health Literacy Association forward. And thank you, Antoine, for hosting us. And thank you, world, for joining us.
My name is Christina Sørensen. I represent here also Health Literacy Europe, and we are bringing the Asian Health Literacy Association, our US partners. And we have greetings from South America and from Africa. We couldn't fly in. We are now live streaming today for this launch of our new association. So welcome, everyone. You know, you don't exist if you're not on the internet. And we've been working very hard to be on the internet from today. So I'll ask our technical miracle maker, and he will let us know when we can count down.
We are online now.
We are online now,
We have
so
been.
you can find us on the internet with a new webpage, and it's called www.i-HLA, and we hope that everyone online will go to the webpage and sign up to our new association. RV is showing you right now what it is. Here we go. We are here. We're existing.
Yay.
So this is the home address.
This is the
Alright.
home address,
Right.
and you will recognize the I-Health Literacy Association. It is possible for everyone now to go to the website and sign in and sign up today. And if you do that, RV, you will see that we are looking for people who are interested in different topics to sign into working groups. If you click Get Involved, you can fill in the form and you can sign in if you're interested in information only, or can you scroll down, or to different interest groups that we're setting up. And we'll be talking about this later during the day. We are not the only event that takes place here in Geneva. We are making it a 3 regional step. So we have now the European meeting. Next week there will be the conference in Washington with our American colleagues, and then Peter is heading the Asian conference where we will also launch this association. And in order to ensure that we actually reach everyone, we are making a symbolic action, lighting a candle that can help pave the way, show the light, give us spirit for the new association. And we hope it will burn and inspire everyone to help us mobilizing on electricity advancing constitution. Welcome to our new guests.
So you mean like a torch?
Yeah, so we will let it burn today here in Geneva,
Oh.
and then Sabrina will take it on to the conference next week in the US. And Peter will go to the US and he will bring the candle with him to Vietnam in November, and then we make the circle. If ever there will be conferences in Africa and South America, they can get our candle.
We'll take it all over the world.
Thank you, everyone. We are now looking forward to the contributions that we have today. We felt it was important to set the scene and give examples of what is already happening in the field of health literacy. Yeah.
I did just want to, before we really dive into the presentations, just to thank our sponsors. We have a number of sponsors. The Institute for Healthcare Advancement is one of them. IHLA. We have the Immigrant Center, the International Center for Migrant Health, right?
And development.
And development.
Yes.
We have IHLA, the Asian Health Literacy Association. We have, of course, the University of Geneva, Tufts University, Health Literacy Europe, Health Literacy UK is also, an organizer. Help me out here. We have a whole group of them. There's the World Federation of Academic Institutions for Global Health, another. The Asian Educational, Scientific, and Cultural Organization is also co-sponsoring.
University of Haifa.
University of Haifa.
University of Konkan from Thailand.
Konkan, yes. The World Health Organization, of course, and others.
The Global Working Group on Health Literacy and the IUHP, the Global Working Group.
Yes, IUHP and the Global Health
Working Group
on Health Literacy, and we have others as well, but I just wanted to be sure at the beginning to begin to acknowledge that support, and we're looking for additional sponsors and more organizations and universities, nonprofits, and individuals to join us.
Yeah. So before we start with our content, I have some practical information. We are live streaming throughout the whole day, and it will be available on YouTube in the launch period. And then we will make a report from the 3 events, and it will be shared as kind of a founding document for our association. For those people here in Geneva, there is coffee and cakes and fruits. Our facilities are down in the corridor through the grey door, going to the left for the gentlemen's, going a bit further on, following the posters for the ladies. Don't get lost in this fantastic building. It's easy to do, it's so beautiful. We also have some sign-in sheets here on the table for everyone to give us your contact details and to know who's here. People who are signing in to the live stream, we have their contact details as well. And there are name sheets for everyone, so we hope you will have a really nice and fantastic day. We will start with Professor Jürgen Pelikan. To give an example of the Austrian and German-speaking countries, with concrete examples of the work that has been carried on. Jürgen has played a key role in the European Health Literacy Survey and the questionnaire. And in Austria, your government has decided to have health literacy as one of 10 political goals. A platform, a network has been created, and I know Jürgen Pelikan will tell us much more.
Good morning, everybody. Yeah, it's better here. Good morning, everybody. It's a pleasure to be here. Thank you for giving me the opportunity to speak of 3 countries, which are called sometimes DACH, for Deutschland, Switzerland, and Austria. And I'm very glad that I will have the opportunities to say a little bit about the Health Literacy Survey Europe, because that was the stimulating driver which got all these things going on.
Jürgen?
No.
Okay. You see, I will talk about these things a little bit about measuring population health literacy, because it was measures and benchmarking for population health literacy which really pushed it on. I will give you then some data and some examples what happened by when these data were published in these 3 countries, and some joint initiatives and the conclusions. Yeah. Next, please.
Mm-hmm. Sorry.
Well, you see, for measuring population health literacy, you'll need a broad, comprehensive definition of health literacy, a definition which is about knowledge, motivation, and competences to access, understand, to trace, and apply information, to take decisions in everyday life, not just as a patient in healthcare, in terms of healthcare, disease prevention, and health promotion, to maintain and improve quality of life to the life course. That was our definition. For this definition, we developed a measurement instrument with this matrix. For every cell, we had 3 questions. Next, please. To give you an example, what kind of questions did we ask to measure it? For example, on a scale from very easy to very difficult, how easy would you say it is for you to understand what your doctor says to you? Or to find information how to manage mental health problems like stress or depression? Or to understand food information on food packaging like that. Thank you. Yeah, for analyzing the data, you see we didn't only look here what is the distribution and the means, the standard deviation of health literacy, but we looked what are personal determinants of health literacy, and of course we looked at consequences of health literacy. How is health literacy related to health behaviors? How is it related to health status? And how is it related to illness behaviors? Yeah, very important, talking about health literacy, is a correct understanding of health literacy. Health literacy has to be understood as a interactive or relational concept, That is, health literacy depends on your personal skills and abilities, but at the same time it depends on the demands, on the complexity of the systems where you have to use health literacy. Therefore, health literacy is this kind of concept, and you can measure it here and here and here. We did measure it, the relationship, and of course you can intervene to improve individuals' health literacy. You can improve resources and demands of institutions, and you can do some compensatory things. For example, for people who don't talk the language, you have to offer translation. Next, please. I won't go into that. You see, we were working in a country sample of 2000. We did personal interviews. I think that is enough to know how we got the data. Now, some survey results. I have to apologize because it's in German. Inadequate, problematic, adequate, excellent health literacy. What you see here, if you're looking at the 8 countries together, 12% of the people have inadequate, 35 have problematic, and if you put that together, you see nearly every second person has limited health literacy in these countries. But for the countries I'm talking about, it was not important like that, but for Austria, for example, it was very important that in Austria, inadequate was worse than on average. And in Austria, and therefore in Austria, more than 50%, 56% had limited health literacy. For Germany, only the biggest region was taking part, and it was not very good either. Later on, Switzerland made a survey, and Germany made a full survey, and you see again that they are rather like here, and not like Netherlands or Ireland or the country which are very good. And this benchmarking really was a shock in these countries. Next, please. I just gave you averages for the population. If you look at specific vulnerable groups, you see that up to 3 or 4 people have limited health literacy when they have a bad social status, if their self-perceived health is bad or very bad, or they are not able to pay for medication, or their income is bad, or they are older. And you see here for the 3 countries, but for Germany also you have two rows, because you have the first study only in North Rhine-Westphalia. Of course, it's a very well-developed country, therefore the results for total Germany are worse than for that. Next, please. There's a social gradient for health literacy. You see these socio-economic and socio-demographic indicators together are explaining from 10 to 23% of the variation of health literacy, and you see the best predictor is financial deprivation. People with with high financial deprivation have low health literacy. And you see, and I think that's important, all these figures vary between the countries. The effect is much stronger in Switzerland than in Germany or than in Austria. Next, please. Of course, health literacy is only important if health literacy has consequences. And here we see there are associations with lifestyle indicators. The strongest one is with physical activity. Again, you see big differences, much stronger in Switzerland than in Austria or in Germany, but there is a strong relationship, less for body mass index, alcohol consumption, smoking. Next, please. Here you see that it's really a social gradient. You see, we built an index, and if the index is low, going up from 0 to 50, you see the number of people who say that they are doing physical activity almost every day goes up like that. So there's a real gradient. The higher your health literacy, the more you do physical activity. Next, please. And we can show, if we control for socio-demographic indicators, we see that health literacy is the strongest predictor of physical activity. Stronger than age even, or than gender or education, the strongest one. Next, please. The same holds true. The same holds true if you go to self-assessed health. Next, please.
Mhm.
Again, self-assessed health, even if you control for many other variables, self-assessed health is the third strongest predictor of self-assessed health. Next, please. There's a slight association as well with doctor's visit. People with have higher health literacy are less using doctors. Next, please. Again, health literacy is the third strongest predictor of doctor's visits in the population. Next, please. So making a first summary, limited health, why is health literacy so important for policy? Limited health literacy is a problem of not a minority, but about every second citizen in these countries, and there are disadvantaged groups with much higher percentages. There's a social gradient, health literacy has consequences for health, lifestyle, health indicators, disease. Therefore, strengthening health literacy is a strategy to improve population health and tackle the health gap. Okay, next please. So, next please. You see, in Austria, we did the study, we took part, we did something more because in our country, health is very much a regional matter. There we wanted data for the regions, we had a bigger sample for the regions. We were looking at the health literacy of adolescents, we are looking at the health literacy of migrant groups with Turkish or Yugoslavian background, and we did something else. We started to develop an instrument for assessing health literacy of hospitals and piloted that, and we did for the government collections of best practice health literacy measures which work. Next please. In concerning policy in Austria, there were 2 documents before the survey which at least mentioned health literacy, but we were very fortunate that back then when we had the first data, Austria was just in the process of defining 10 health goals. So strengthening health literacy was included. It became the 3rd health goal. It was prioritized. There were set up working groups to develop measures for that. It was within the Austrian healthcare reform, measures were implemented and planned for. We started to have an Austrian platform for health literacy with members from all sectors of society, with annual conferences. This conference is next, the conference of 2016 is next week, and the topic is communication as a driver for health literacy. Next, please. Looking at Germany, you see Germany was included by North Rhine-Westphalia, but that was not enough. Very early, the German health insurance companies went in and did their own study on their insured people. The same did the private health insurance. The Robert Koch Institute, which is an official public institute in Germany for public health, started to include our health literacy measures, a short one, into its routine. And then, of course, in Germany, a survey of whole Germany was done, and specific surveys on vulnerable groups. Politically in Germany, a network was found, and there's now a working group on making a German action plan for health literacy, which was stimulated by a foundation and by people from universities, but the German Minister of Health took the sponsorship for that and will support this group, and the German Minister for Health plans an alliance for health literacy in the future. Next, please. Switzerland, you see, Switzerland started very early, but MSD financed a study in Switzerland already in 2006. That stimulated some debate. Unfortunately, Switzerland couldn't take part in the original study it wanted, but now, because of the impact the study had in other countries, the survey was done in Switzerland as well, Bevölkerungsfragung, Erhebung, and now there are quite a number of debates in this country. Next, please. Yeah, a first debate was after the first study. Health literacy was integrated in the public health strategy. A Swiss alliance was formed by different partners. Health literacy is included in the Health 2020 debate in Switzerland, and now because there are the data now, there's a process going on after this kind of diagnosis, what in Switzerland should be done, and there is a collection of health literacy measures which work. Next one, and last one. You see these three countries together have some initiatives because their ministers of health regularly are coming together. You see there was a German translation of the Solid Facts Health Literacy of WHO. That was an initiative that interested parties from the three countries came together, formed a kind of consortium with regular meetings and with action plans. And you see at the fourth meeting of the German-speaking health ministers, the ministers said strengthening health of citizens was an important topic. The ministers proposed a Europe-wide institution of regular international comparative health literacy results. A working group was formed, and they called on all relevant international institutions, especially WHO, to support this initiative. Next, please. Yeah, conclusions. Evidence demonstrates that health literacy matters for individual and population health, for healthcare practice, and for health policy. But to get necessary attention, agenda setting, and investment in research, practice, and politics, health literacy has to be measured and monitored regularly on the level of populations and of organizations, not just of people, but I think of organizations as well. Benchmarking of results stimulates public debates and policy for health literacy, as an example of the three DACH countries demonstrates. Therefore, last conclusion, it is important, go back
Sorry.
it's important to institutionalize regular monitoring and benchmarking of population health literacy for agenda setting, diagnosis, and evaluation in as many countries as possible, hopefully supported by WHO, as already the WHO Solid Facts Health Literacy tested in 2013, and next here you have this Solid Facts. Well, thank you for your attention. You all are invited in your country to stimulate the same so that we can form an international consortium of measuring health literacy like the health literacy in like the Health in Children and Youth initiative of WHO is doing. Thank you so much.
Jürgen, thank you. Before you sit down, Joe, I think you're next. If you want to get your information up, and then we have one question maybe for Jürgen. He's coming, so we're going to have to. Do we have any questions for Jürgen before I ask a question?
Was it clear enough so you can follow the conclusions in your country and in your own institution?
Right, so I have a question.
Very good.
So two things. One is, can you tell us a little bit about the measure you're developing for assessing health literacy in hospitals?
Yeah.
And then the other I'm interested in is to tell us a little bit more about migrant experience.
Okay, first measure, you see we followed a little bit IOM, but we broadened it because we thought health literacy is, even in healthcare, it's important that health literacy is used for prevention and promotion as well. And we thought it's not only important in healthcare to have health literacy improved for patients, but it's very important for the staff and the community as well. Yeah? And therefore we developed 10 standards with sub-standards with indicators to measure it. I will talk more about that in Prague, in Bethesda next week.
Great.
That was one question. The second question?
Anything more you can tell us about your region's experience with migrants?
Oh yeah. You see, in all the three countries, migrants' health literacy was measured. Usually it was worse than with the with the original population, whatever that means. We developed a specific measure with tasks which are important for migrants and found that with tasks migrants are worse as well. So therefore we think, of course we can use the core measure we have, but we need measures for specific vulnerable groups, including the tasks which are important for them, and then we have a good diagnosis to help them. In our case it was interesting that the main associations were the same for the migrants, partly a little bit worse, And of course, the migrants had different problems to understanding the healthcare system, and things like that. And not only to understanding it and to navigating it, but as well how they were treated by the health. And there was some kind of discrimination. And therefore, I think we have to do something that migrants, at least in our healthcare system, are treated as equal as all the other people there.
Thank you for
Thank
your
you.
questions.
I know we have another question, but
That's good. We
We
will
should
have
go
a
on
panel
to Jill
discussion
and-
if so.
Okay.
You can consider. Thank you, Jürgen.
we have a couple of new guests.
Yeah.
Thank you.
So let me introduce our next speaker. Actually, we have two speakers, but it will be you're one speaker, but two representatives from the UK Network on Health Literacy. We have Jill Rowland sitting here, and John Portero, who will give us some introduction to the work that has been carried out in the UK. Thank you, Jill.
And I'm going to just interrupt one more thing. We do have, this is where it will come from. We do have a hashtag, so if folks want to begin using that.
Okay, thank you. Okay, thank you very much for inviting me to come and take part in this great initiative this morning. My name is Jo Prothero, and I'm speaking on behalf of myself and Jill Rowland from the UK. So, just a little bit about me first. I'm a family doctor, a GP in Manchester in the north of England in an inner city practice, which is quite a deprived area. I'm also a senior academic at Keele University and also chair of the UK Health Literacy Group, so we're delighted to be a part of this. Just a little bit about the UK Health Literacy Group. You can just move the next slide on, just in case anybody's interested in having a look at us. We're mostly a web-based group. We have about 700 or 800 registered members. We communicate lots of things through the website. In fact, we have over 2,000 Twitter followers now, so if you want to advertise on our website, we'll link you through, at least we'll get some more people. And we tend to run 2 or 3 seminars a year, moving around the UK, sharing innovative health literacy practice and up-to-date research in the UK. So it's a really stimulating and exciting group we have got going there. We also run a conference as well every couple of years. Okay, so the title of my talk this morning is Health Literacy Interventions That Work. That's quite a tricky title. If you think about that, first of all, that's 2 big things that are quite controversial. What is a health literacy intervention, first of all? Are we saying that health literacy is a risk and that we need interventions to change the health system, to take health literacy into account, the universal precautions, look at health literacy? Or are we saying health literacy is an asset and that we're wanting interventions to increase the health literacy of a population? Or are we talking about all of them, or all of those interventions, health literacy interventions? And if they are, then a health literacy intervention can be as big as a law in a country that improves the health policy, regional community action policies. It could be as tiny as the interaction between the healthcare professional and the patient in the consulting room. Second big controversy around this particular title of talk is, how do we know it's worked? That's a major issue. What are we measuring? Are we looking at improved health literacy, improved health outcomes, improved empowerment, reduced inequalities, inequities, or all of them, or none of them, or some of them, many more outcomes? Okay. I think we can all agree that health literacy is a complex and evolving concept with no universally accepted definition or measure. We can all agree, we slightly disagree, but there's a core component to it. Christine did a systematic review not that long ago which showed that there was, at that time she did the review, there were 17 different definitions. There's probably more now, multiple conceptual models, and over 50 different health literacy measurements, and again there's probably more than that now. Next one. So what I'm going to talk to you about, the main focus of this talk, is a report that Jill and I were involved with, and I think some others in the room, Diane was involved, where a report was commissioned by Public Health in England to have a look at health literacy interventions that work. What's been effective in England, strategies and interventions. So this is the report that came out this September last year, Local Action on Health Inequalities, Improving Health Literacy to Reduce Health Inequalities. You can find that on the internet, it's freely available. Next one. So this report concluded that efforts to improve health literacy have a range of benefits: increasing knowledge, building resilience in the population, encouraging positive lifestyle changes, much like Jürgen's just mentioned, empowering people to effectively manage their health, decreasing the burden on health and social care resources, which is exactly the mirror image of what you found health literacy to be a problem in the European Health Literacy Survey. But the report concluded, as Jürgen said, we need more evidence. We need more evidence of economic change and social change that we can give to policymakers so that they will make a difference. Next slide. In this report, we define health literacy interventions or initiatives as a strategy, programme or initiative that may contribute to the health literacy of individuals by strengthening individual skills, by simplifying, clarifying health information and systems, or engaging underserved, disadvantaged or vulnerable groups through general literacy or health literacy interventions. There was an attempt to be as broad as possible so that we didn't miss any health literacy interventions or initiatives. The report then categorised these types of interventions and initiatives into 4 main groups. So what I'm going to do next is list these 4 main groups, and then I'm going to give you some examples from my own research and practice in Stoke to give concrete examples, and these are representative of the categories, but obviously there are many more interventions in the UK that you can see by looking at that report. So this is Stoke-on-Trent. It's in the middle of England. We measured its health literacy in Stoke-on-Trent in a local survey and found that we were equal to Bulgaria on your health literacy scale. It shows that the health literacy of Stoke-on-Trent as a population is not very good. It's an industrialised city, and the industry was potteries, and that's no longer a current industry, so there's a lot of socioeconomic disadvantage in Stoke. The health of people in Stoke-on-Trent is generally worse than the England average. Deprivation is generally higher than the England average. Over a quarter of children live in poverty. Educational attainment is lower than the England average, and life expectancy is lower than the England average. So it's not surprising then, given what we've already said about it being a social gradient, that health literacy in Stoke-on-Trent is lower than the England average too. So going back to that Public Health England report, the first category of interventions was health and social care service use of simple teach-back methods to check service user understanding. So my example from Stoke is we have started for the past year or so, we've got health literacy training and awareness courses. We've been delivering these to professionals, a broad range of professionals, not just health professionals. So we have general practitioners, family doctors and GP practice personnel, pharmacists, dentists, school teachers, educators, participatory art group leaders, social workers, local authority planners and commissioners, fire service professionals. So that's, and more. That's just to give you a taster of the broad range of professionals we've included in this course. The content of the course has been around what health literacy is and why it's important, how it can make an impact in practice, looking at healthcare practice, how patients or service users can have difficulties in attending appointments, taking medication, understanding their condition and self-managing their health. So really trying to raise awareness among our professionals that deal with patients and service users of health literacy as an issue and why it's important, and then using giving some examples of tools that they could use, such as Teachback and Check and Chunk. Next one. Just looking at the healthcare professionals, last year we trained 285 practice staff. This is just in Stoke, remember, so that's pretty good. We're not a massive city, of whom 70 were GPs, and they attended half-day or full-day courses run by the Community Health and Learning Foundation. The website for them is on that page. Sorry, was that the... Skip forward a slide. Yep, we're on the next one. Sorry about that. So that was the first category and an example from my local practice. This is the second category from that Public Health England report. That the category of intervention or initiatives was an early intervention approach to health literacy, ensuring it's fully integrated into early years and school curricula, as well as in health and social care professional training. That's kind of two ends of the spectrum in one category, but still. A couple of examples then from our local work. This is an example of getting health literacy into the early years curriculum. This is Stoke Speaks Out, which is a multi-agency organisation delivering speech and language and communication across the city to nursery school, childminders, early years schools, anybody that's got any kind of influence with children, preschool children. We've developed these boxes, like dressing up boxes, story boxes, which uses health literacy knowledge, and the projects are intended to immerse children in health-related vocabulary in a play-based and multisensory way, providing children with a core foundation of vocabulary on which to build later learning. And we've got 4 health literacy resources at the moment. We've got them going to the dentist, going to the hospital, going to the doctors, and healthy eating. And they've been very popular with the early years school children, and the speech therapists who've been running the project have been really enthused about how this is really improving children's vocabulary, particularly around health. Next one. So at the other end of the spectrum, remember that category considered both early years and also medical and health professional education. We've managed to get, and it's a very long, hard-won battle to get into curricula of medical school training. So we have managed to get a health literacy lecture as part of the public health teaching to second-year medical students, which I do every year in Kiel. Okay. Next one. The third category of health literacy initiatives and interventions are community-based peer support approaches to health literacy that help to distribute health literacy among social networks. This again was from the, remember that public health report. So an example of this from Stoke is, next slide, the Cultural Sisters. These are a participatory arts organisation who've attended our health literacy training, and they have a focus on arts and health, and they engage with people using creative processes to explore and learn about health and well-being issues. They've taken health literacy concepts into this and embedded into their project development, enabling people to help each other and themselves. The fourth category of interventions is about empowering professionals through continued education and interdisciplinary initiatives to improve health literacy and strengthen public professional communication. So my example for this is how that we have managed to get health literacy into our local quality improvement framework. So there is a national requirement in England that health professionals demonstrate that they are undertaking projects to improve quality of care. It's a national requirement, but the topic that you choose to do and targets are locally commissioned. So practices, family practices, GP practices receive incentive payments for participating and achieving these targets. So this year we have managed to get one of these quality improvement frameworks to be health literacy. And we've used clinical audit to improve clinical advice and patient self-management plans through improved health literacy of the practice environment and of the patient population, recognising that one cannot be improved without the other, much like that diagram that Jürgen had in his presentation just before. Next one. So as part of this quality improvement framework, it's a prerequisite that health literacy training, either online or face-to-face, has to be undertaken by the practice staff, and then they conduct a significant event audit where they select cases of patients with poorly managed long-term disease conditions, and one GP in the practice is the clinical lead for the audit. For each case, a lead GP reviewer and 2 other practice staff compare clinical management and care over the previous 12 months and think about how we could improve. So those are 4 examples locally of the categories of health literacy interventions in the UK. And the report, key messages of the report were that the available evidence suggests that strategies to improve health literacy are important empowerment tools which have the potential to reduce health inequalities, because the most vulnerable and disadvantaged people in society are at risk of limited health literacy and are known to have the poorest health outcomes. This is a direct quote from that report. Another direct quote: further, large-scale, robust and clearly defined research is needed to better understand the effect of health literacy interventions on health inequalities. This should include research focused on how best to improve the health literacy of disadvantaged or vulnerable people, the effects of such initiatives on clinical and health outcomes over time, and more research on cost effectiveness. So, health literacy interventions do work. That's the title of the topic. We need more evidence to support and develop interventions and initiatives, and this International Health Literacy Association is a huge opportunity for us to all get together, researchers and practitioners, to share our learning and develop and evaluate health literacy initiatives. Thank you.
I think you are now mentioning a very important point, that we want this new association not only to be a research society, but really embracing people from practice, people who are teaching in schools and professional development, people who are in policy and people who are decision makers in the management levels. We need everyone on board, and we hope that with the topic of health literacy we can reach as many as possible, and especially now with our new platform here, International Health Literacy Association.
Any questions?
Any questions? And while we have the questions, our next speaker will be Arvi. Yeah.
Yes, thank you very much for your presentation. Very, very interesting. I want to ask you the age of the children where this material you preparing for them. What is the
For the story boxes.
Yeah, yes, exactly.
Preschool. So school starts in England in the year of your 5th birthday. So
Yeah.
under 5s.
On the 5,
Yeah.
okay.
But nursery age. So generally, sort of the youngest age would probably be 2.5, 3. So that little group of
Okay,
toddlers.
and it means that it's not don't contain written matter. It's only images.
Well, they get the boxes have some written matter, some sort of
Yeah.
word vocabulary cards, but more it's about getting them to dress up in boxes and play, role play. Well, we'd call it role play as adults, they just call it playing as children. Going to the doctors or going to the dentist and talking and getting those words into their vocabulary.
Wonderful. This is
Yeah, it's a very nice idea. Mr. Logan?
Rob Logan at U.S. National Library of Medicine, National Institutes of Health. Let me talk about the first two presentations together for just a moment. Most people who understand health literacy begin to understand it through the second presentation. Okay, they begin to understand it as a problem that's strongly associated with vulnerable populations. That's the word we use to talk about low income, low educational attainment, and low socioeconomic status. But the issue that I think surprises people and that is hard to let people understand is what was said in the first presentation. That health literacy is much more than a problem of vulnerable populations. It's a problem that cuts across all demographic areas of a population. And I believe our future, moving ahead, is to show both simultaneously, continue to work in both areas. Because I believe our future, and certainly in terms of you're concerned about, and for that matter, the folks in the UK, they're concerned about policy. We have a strong argument to make. We want to improve the health, welfare, life course of persons in vulnerable populations. We have strategies. But not only that, we can do much better. Okay, we can actually, by looking at things a little differently for other groups or other populations, make a significant difference across the entire population. So again, I encourage all of you. This is not what I'm going to talk about this afternoon, but all of us need to understand that most people do not make the jump between the first issue and the second. Most people are very willing to associate health literacy with vulnerable populations, but most people have great difficulty associating health literacy with across the entire population.
But what we try to do in our area is deliver our interventions to everybody. So we're not just delivering them to vulnerable populations. Yeah.
Thanks.
Diane, and then
Okay, thanks so much for your presentation. Diane Levin from Israel, Clalit Health Services, University of Haifa, and IUHPE Health Literacy Working Group. Just a question, and it links up with what Rab said before. Yeah, I think we're looking at also the attitudes and the positions of GPs and primary care health workers also on issues of health literacy. And I think when it comes to their own health literacy, when they have to experience health decisions and use their skills, sometimes those challenges are then experienced what Rob just mentioned. So my question to you is how were you able to get primary care GPs on board for health literacy? You talked about training. What is your best tip for encouraging GPs and primary care health workers to be interested in health literacy?
Well, we've done pretty well by just getting them to come along as being interested, because we've made it a public health priority in our region. And that has worked pretty well so far. As I showed you the figures, we've got a lot of our GPs to come through training without offering any incentives particular, just out of interest. And then in addition to that, we now have got it in this quality improvement framework, which will give an incentive because there's a financial incentive attached. So both. Carrot and
we have a last remark here before moving
Yes,
on.
concerning the
Question.
discussion that Dr. I don't know
Rugon,
his
yeah.
name. I am thinking that there are 2 or 3 very important institutions that should be incorporated in health literacy. One is the civil society in general. This is clear about your example. American staff, of course, but the other is the school. This is fundamental, and the other is mass media. It is television today and social networks are the main way of transmitting information. Now, the problem is that it is important to have only one kind of messages, because sometimes messages sent by television, sent by the school, and sent by the health staff are different. And the problem is how to integrate and how to promote only one message is using these different channels.
Very good point. Thank you so much.
okay, thank you very much. Thank you.
Now let me introduce our miracle maker. He's the reason that we were able to be online this morning, that we exist basically. RV has from the United States.
I wouldn't say that now.
Has also played a major role with colleagues in the United States on our new logo.
Well, and around the world.
And
Jill,
around the world.
Jill,
Yes.
Sabrina Kirk-Rossi,
Many
Julie
people
McKinney.
have played a big role. You're now here to talk about your research on health literacy and equity and our new agenda, new global agenda.
New global agenda. Not so much my research, but to think about, Rob, you just walked into what I was thinking about in terms of my talk. I had a PowerPoint slide set up and all that great stuff until last night when I was talking with Christine, and I thought, nope, throwing that out the window. Why are we having an International Health Literacy Association? What's the purpose? The purpose is that we need to bridge and bond in terms of our knowledge, what we know, and what we do. That we have interventions in different places around the world going on. Practitioners need to be just as interested in disassociation as, say, the researcher. Policy members need to be just as interested, because what works one place, one intervention, may in fact work somewhere else. It's the sharing of knowledge, sharing across the divides. I would also say, in terms of the equity, health equity, equity meaning access, equal access to health care, the opportunities to have good health outcomes, right? Where does that start? Where do you find that knowledge? It's certainly not sitting in this room. It's out there. It's people in communities. That's where you have to start. Working in communities to understand the needs of folks who live there. We talk about social determinants of health and creating health equity. We do that by going into communities, talking with people, understanding their lives. That's what health equity is all about. An association such as this one I hope, will facilitate a growth in health equity so that there is an opportunity for all to not have disparities. The big connection here is, here's health literacy. Here's health outcomes. This is the goal, right? We focus on this, but the connection's up here. That's what we really need to do, is understand, if we want health equity, how do we create? We're doing it, don't get me wrong, measurement is important, but we need to be able to work across and not in our silos if we're going to have equity for all. That's all I have to say, honestly.
I think it's linking up very much to your photos, Joanne, saying really from being out there, we sense it, we see it. And are there any questions for RV? Yeah.
Well, I think you good to mention this, but I'm wondering particularly how the new social media, internet, this can really help him.
Yes.
Because
We'll be
if this is
talking
10, 12, 15 years ago, maybe it doesn't work, but how can we use?
How can we use it? Okay, understand who your audience, the audience you're trying to reach. So if I'm trying to reach, let's just say, women who are in their 40s or 50s, and they have just gotten a breast cancer diagnosis. Guarantee you they're going out to Dr. Google and doing a search, and they're going to come across an organization, a group called Breast Cancer and Social Media, hashtag BCSM. I know the folks with that group. That group serves as a large social network. It's virtual, online. They provide social support to each other. How do we reach? It's knowing who your audience is. Number two, understanding what messages they get. In other words, going and understanding how do you craft the message for that group. So a lot of user testing, but social media is the platform. I think it's a platform. I don't think it's the platform. But if it's just that one thing that catches someone's interest, and they're like, oh, so that's what that means. And then that's passed on to the next person. Does that answer your question?
Yeah.
Thank you. I'll be talking a little bit about this a little bit later on e-health literacy, but I think using your example, RV, I think it's also really a great opportunity to mention critical health literacy.
Yes.
Because if that same person who's just received a diagnosis on breast cancer goes into Dr. Google and finds a group that says, don't go to conventional care, just use natural care, and there isn't any kind of critical thinking about, is that
Yes.
good for me or is that not good for me?
Exactly.
Then I think we have to rethink what the role is of social media, internet, e-health
Credible.
literacy, to empower people to be able to judge that
Yes.
information for themselves.
Yes, absolutely. I agree with you completely. Because you just can't go on WebMD, for example, or I'm sorry, I apologize to the WebMD people. There has to be credible sources. In social network groups, I found you do generally have, to some degree,
Yes.
credible sources there, people living that experience as the other person is living it and providing that social support.
Thank
Agreed.
Jill Rollins?
Yeah, thank you. And thank you very much for a very stimulating presentation, and all of them today have been really good. Just picking up, I think, moving on from what Diane has said, the other huge advantage of social media platforms is the opportunities for distributed health literacy, and for the health literacy of that social group as a whole to increase and to share skills and resources. And if that is well managed, that can be a huge advantage. So for instance, I'm doing some work with an organisation that supports people with rare conditions. So that's I think 5 in 100,000 or less. So you can have conditions where there are only 2 or 3 people in the country who have it, or a country the size of the UK, but they're devastating illnesses. And actually, opportunities like social platforms mean that you can pull together a global group where there are enough of you to be able to share knowledge and information. And I think capturing that, holding that tiger by the tail is a huge opportunity to promote health literacy within social networks.
Please.
Yes, following this very interesting discussion or analysis, I agree absolutely with all the things that you are talking about. I am thinking also how to stimulate, how to promote the contact, not only between, you have here different systems, research, health staff and practitioners, the population, the community, etc. Now, usually research is conducted, maybe, we hope, with practitioners and maybe with the population. But the problem is how to promote the circulation in the system, and more important, how to promote the horizontal circulation between communities. Because each community has a lot of experience, a lot of problems, and probably the problems and the experience is more or less similar. Now, using social media, maybe we can promote this contact with different communities or different parts of the communities. I am thinking, for example, adolescents that are using social networks enormously, and establish some kind of teaching themselves. And there, researchers and social workers and so on can introduce information, but the problem is that this information should be adapted, transformed, digested by their own community and circulating them. If we can do this can be useful not only for health literacy, but for any scientific information or for any information. And this is, for me, promoting empowerment.
Yeah. I think we see more and more of the peer education, but also how citizens are now actively getting involved in research and recruited. There's a Danish diabetes management study where people can sign up. So it's not they are handpicked, but they sign up. They have more than 70,000 participants sharing their story, and suddenly the researchers are able to make analysis they weren't able to do before, and people are willingly sharing, and it's a way also to increase their health literacy. We have one last remark here.
Good morning, my name is Faten Benabdelaziz and I am coordinator for health promotion at WHO. I'm very delighted to be here with you and thank you for accepting my participation. From my perspective, the presentations were very interesting and quite informative. But if I may also make comments on the approaches that are, as you know, we have 6 regions and each region has a different context. And I believe that actually when we speak about literacy of individuals, communities or health professionals, it is very important to actually assess the basic knowledge of that particular context. So starting where people are.
Meet them where they're at.
Exactly. That's why I liked very much your comments when you talked about SDH, social determinants of health, and others. And I think, as you have mentioned, we need to build on what is existing, because otherwise you have no communication, you have no linkages. And I would say assessing the basic level of literacy of the population we are dealing with, it's understanding better the context, as you have mentioned. But when we speak about social media and involving new innovative technologies, we also need to refer to the private sector. While we can have some very fruitful basic partnership or some part, there is also here the area of conflict of interest that we need to actually assess. So when we speak about literacy, I would like you to think of these different aspects that we in WHO somehow are also missing. We don't know too much about all these areas, but your association can help out in addressing these issues, but also finding some solutions about this. So I just wanted to raise those points so that we can.
Absolutely. And my concern in terms of using any sort of new technology is creating another digital divide. That is very profoundly, as a sociologist by training, whether it's just a mobile phone or a social networking site, I'm concerned always, and that's why I say go to the community, understand what is the message system. It might be, the only message system might be I talk to you, you talk to somebody else, you talk to somebody else. So then social media, throw that out. It's now face to face.
Yeah,
Don't create another digital divide.
I agree. And please bear in mind that actually health literacy is actually what triggers social mobilization.
Yes.
So I would say this is, if everybody has the right knowledge and again a common interest and common motivations, then you can create some kind of movements, joint movements, and from different. Can I take the opportunity to actually make some publicity for our upcoming conference?
Yes, otherwise I would have done it. I had it on my lips. Please.
So as you know, we will have our 9th global conference on health promotion in Shanghai this year, and I hope to see you. There is a special session on health literacy, and it addresses many, again, health
One of the
literacy of
three
migrants.
main topics
Exactly.
is very high on the
Exactly.
agenda.
So if you need any information, I'm here, but I would love to see you there and enrich the conversation that will take place there. There will be a strong focus on policymakers. So basically, around 70% of the speakers will be policymakers, ministers of different sectors. So it will be a good platform for you to challenge them and also enrich their knowledge, because health literacy of policymakers is not sometimes to the level that we would like them to be. So please,
Thank you
do join.
Thank
very
you.
much.
Thank
For this thank you, Arnie, for your intervention. Before we will have a short coffee break, I will take this opportunity to just make an introduction round. We didn't do it in the beginning. People were coming in, and some people already introduced themselves. But just to know who is here before we go to the coffee, so you can find the people to talk. Can we start behind with you? Yes.
Hi, I'm Elizabeth McLean. I'm with the International Centre for Migration, Health and Development. My main focus is on diabetes.
Dr. Rob Chiari, I are working in the same station, ICMHD. I am working in education, training, communication, and my basic concern is how to transmit to the population basic scientific knowledge and how to promote the use of this scientific knowledge in the population. And health literacy is one of them.
I'm Kervarati, I'm an intern at ICMHD, and I'm also studying human rights.
Okay. Thank you. And
Fatima Ben Abdelaziz, Coordinator for Health Promotion at WHO Headquarters in Geneva.
Jürgen Pelikan from Vienna. I'm an emeritus professor of sociology at the universities there, and I'm director of a WHO collaborating center for health promotion, hospitals and healthcare at Gesundheit Österreich.
I'm Rachel, I'm an intern at ICMHD studying development.
I'm Ina, and I think we're all from the CMC here. So, working on HIV, viral hepatitis, and generally on migration and social integration. I'm Wongsa Lau Hasrivo. I'm from Konkan University, Faculty of Public Health. I'm the Vice Dean and the Chairman of the doctoral program. And now I'm responsible for migrant health, because we have like more than 30 students from Myanmar. Most of them are migrant, and I enjoy the work for migrant.
thank you. Welcome.
I'm Gianmarco Segre, working at the permanent delegation of the European Union to the UN under the WHO sector.
Okay, welcome. Thank you.
Diane Levin, the National Director of the Department of Health Education and Promotion for Clalit Health Services in Israel, Associate Professor of Public Health in the University of Haifa, and I co-chair with some people in the room the Global Working Group on Health Literacy of the International Union of Health Education and Promotion. My particular interest in research in health literacy is on migrant health, is intercultural, and also e-health literacy, and media health literacy, which I'll be talking about a little bit later.
R.B. Reichard, Michigan State University. I'm a postdoctoral research associate in the Department of Media and Information. I am a wizard of all things digital.
Wizard of Oz.
Wizard of Oz. My research specifically, and research both in the communities, focuses on the intersection of health literacy and health disparities, and then trying to find out from community members, working with community members in those communities, what works, what do they need, what can be developed.
Hi, Lemlem Gurmatzin. I'm from the Institute of Global Health. I work in coordination and programs with the PhD and the master's program that we have here. Today officially I'll be the person that you come to if you need any help navigating this beautiful campus.
Yeah, thank you.
You're a GPS.
Or Geneva literacy.
And thank you for allowing me to join you today.
Yeah.
I'm Lydia Tao and I'm an intern with the ICMHD. My name's Alana and I'm also an intern with ICMHD.
Dr. Rob Logan, Senior Staff, U.S. National Library of Medicine, U.S. National Institutes of Health. I'm a Professor Emeritus in Mass Communication at the University of Missouri Columbia, where I'm also the Associate Dean Emeritus.
I'm a minuscule publishing house that created a book 2 weeks ago and presented it to Professor Kabulina. He liked it so much that he suggested I should come today to talk to you, meet you all. It's so I do a little publicity about the book, a little book called Manger pour la vie, une cuisine africaine. And it's a little recipe book with little icons to promote health for AIDS environment, commissioned by the hospital in Lyon. And well, I'm rather enthusiastic, and we already created a solidarity between artists in Africa. Well, Togo, we only have one for the moment. How to distribute the book, how to create other programs, and yeah, we've only been going 2 weeks. It's already in the hands of the Ministry of Health in Paris, so we're going quite quickly.
Yeah, I hope we also hope that more francophone countries in Europe and in Africa will pick up. And this is one way, through books and communication material. Welcome.
Peter Chan from Asian Health Literacy Association. We are in-house of the ICMHD in Geneva.
Joe Prothero. Joe Prothero. I'm a GP in England and a senior researcher in Keele University and chair of the Health Literacy Group UK.
I'm Jill Rawlins. I'm also a general practitioner, family physician, and a researcher and teacher in health literacy, both at the University of Newcastle in England and Aarhus University in Denmark. And my principal interest is in building practitioner awareness and skills to promote health literacy in their patients.
Excuse me, we have a request from online to speak a little clearer and louder. So, in fact, Diana from Diana G. Guys, correct, from Australia? Yes, she said, please speak louder. So please speak louder.
They had to hear us in Australia.
Well,
good evening, Australia.
With that, I also believe there is an issue around staying within, for their speaker, the scope, speak clearly. We are also going to take a coffee break right now, so I believe
Can you please introduce yourself?
Oh, yes.
I wanted to finish the round.
I'm Sabrina Kurtz-Rossi, and I'm assistant professor at Tufts University School of Medicine and director of the Health Literacy Leadership Institute, which is an advanced professional development opportunity at Tufts in the summer.
Yeah, I'm Christine Sorensen. I've been part of the European Health Literacy Survey, focal point for Health Literacy Europe, and I'm founding now the Global Health Literacy Academy. And I've been working with Sabrina and Peter Chang to start our new association with support from people all over the world. And we thank you, people who are following us. We will have a break now for about 20 minutes.
we have people from online from Australia, Abu Dhabi, Malaysia, and for right now, that's all I can see for right now.
Sounds good to me.
Welcome, everybody.
Well,
Yes.
we started our meeting at 2 o'clock in the morning, East Coast time, US, so I didn't expect anything.
You're welcome, Diane. You're welcome.
So thank you very much. Let's take a break.
All right, we're taking a break. We'll cut the audio off for just a little bit. Now.
Okay,
All right.
thank you to everyone for finding the seats after our coffee break. This morning, Manuel Caballo was scheduled to start our day, and he has now arrived. And we're setting up the presentation on migrant health literacy. As we all know, migrants play now a big role on political agendas, but also then on our global health agenda. And we thought, as an additional theme for the day, we wanted to reflect on the challenge that we have in the world today, on how to tackle, how to handle, how to take care of refugees and migrants that are traveling around the world. In the General Assembly of the United Nations a few weeks ago, President Obama mentioned a letter he had received from a little boy, 7 years old, and the boy wrote to President Obama, "Please come and visit me and bring that little boy who was in a picture in an ambulance because he needs help, and he can live in my family. I have a little sister, and she will share her toy, and you can park your car outside our house. Please come and bring this guy." And I have another friend, he's from Syria, and he's in my class, so they can speak together. And I thought, in that way, if everybody had welcomed another person in our community, in our families, it would be another situation than what we face today. I will speak louder and ask our guest here to speak louder during the day. Manuel, can I ask you to come to our podium?
And speak louder?
And speak louder.
Yes.
Thank
Right.
you.
And come into the scope of the
middle. Right. Here. Always very embarrassed. Good morning, everybody. Sorry to be late. I had other pressing things that I couldn't leave. And I feel a little embarrassed being here. I am not entirely sure what I was expected to say. And so I put together some themes, some thematic slides that you're probably more familiar with than I am. As we just heard, the issue of population movement rather than migration is now becoming a major theme everywhere in the world. In Europe, we are increasingly obsessed by this concept, by this phenomenon, this new dynamic. In fact, Europe is seeing really just the top of the iceberg of a much larger phenomenon. And we need to keep in mind that when we talk about population movement, we are not necessarily or only talking about the movement of people across borders, which is what we are seeing in Europe. The largest migration that is taking place around the world is internal migration. It is the movement of people from the countryside to cities. And we could have a whole debate on urban health and the complexities of urban health. And Dr. Beat Stoll, who has very kindly joined us, someone that I had the pleasure of working with many years ago, the whole issue of urban primary health care is becoming a predominant theme in national and international health debates. Now, I'm not going to talk on that, but I simply want to alert you to the fact that I am going to be talking to you more particularly about what is happening in Europe, but always keeping in mind that this is a very, very small part of a much larger dynamic. So if we can, for those of you who do not know who we are, the International Center for Migration, Health and Development was established in 1995, and it was established by a consortium of UN and University of Geneva Medical School actors. And it was created because at that time there was a growing concern that migration was increasing and no one really knew what the implications of this population movement dynamic might be for health. So the ICMH, International Centre for Migration and Health, as it was then called, was created in 1995. Since then, it's gone on to add a D to the name, development, because our executive board, in a moment of an epiphany, said, but what you are doing is basically development work. And it's very important that we keep in mind that when we talk about health literacy, or when we talk about primary health care, or when we talk about migration and health, we are not talking about emergency medicine. Emergency medicine is part of the phenomenon, part of the response, but we're basically talking about health development and social development. So that is how we got the D. We are a research, training and policy organization. From the perspective of research, most of our work has been on infectious diseases, more recently on non-communicable diseases, such as diabetes and increasingly with Elizabeth, maternal and child health, and so on. In the area of training, we do a lot of training. We take interns, we do training for the United Nations peacekeeping operations. Peacekeepers in the military, by the way, we see as part of the population movement phenomenon. They are on the move all the time.
It's not finding their own.
They have the same health impact. They go through many of the same traumas that refugees and migrants do, so that's why we include them. Good. And then I think this, sorry, can you just go back one? The second paragraph, I think for me, is the most critical part of our mission statement. And that is, by protecting the health and welfare of people on the move, we protect and promote the health of the larger society. So host societies, Switzerland has a lot to benefit from anything that we do for health promotion and protection among migrants and refugees. And any other country will benefit as well. Simply because a bad apple in a, what is it you tell me, in a bad apple in a bowl of apples will infect the rest. And this is something that we always need to keep in mind. We have this unique opportunity in this very, very fast evolving world to use the migrant population as an entry point for a much larger health promotion and protection initiative. So what else did I say? Good. And we believe that health literacy is the key to everything, obviously. I wasn't going to come here and say it's not worth anything. You know? So I know, I really do believe that health literacy, Bert and I were just saying a few minutes ago, that it takes us back, I won't say how long, to WHO's concept of primary health care and community participation. You cannot have community participation, as Dr. Mahler used to talk about it, participatory health prevention and health treatment. You cannot have that if you're working with a population that doesn't understand what it's doing. So health literacy is a key to that primary health care initiative that was started many years ago, but never I'm going to move out of your camera's way just a second, because I forgot what I said last night. And I put this together at last minute. Yeah, go ahead. Very simply, not only the fact that more people are moving than ever before, which every day you turn on your television set you realize that, but the issue is not that there are more people, but that there are more people. How are you? Nice to see you. It's not that there are more people moving, but they're moving further, and they're moving faster. Now, the further issue is that people are moving from one ecological and disease zone to another. And in many cases, they're moving through additional ecological and disease zones. The fact that they're moving faster means that diseases that many, many years ago were caught on ships before people landed in New York, today incubate well after they land in New York. It's a very interesting phenomenon. When I was at Columbia University, we did a spot check of planes at Kennedy Airport. And when all the passengers were off, we took 32 planes and we looked into the luggage compartments, and we found 52 species of insects of one kind or another that were not endemic or germane or indigenous to New York, let's say to New York. In the same way, we are vectors. We, as we travel, are vectors. So this is a key part of our approach to migration and health. And then, of course, those of you who are European know that Europe is caught, literally, as they used to say, with its pants down, unprepared, unaware of the problem. In the United States, there was an epidemiologist called Daniel Moynihan, who many hundreds of years ago coined the phrase benign neglect. And he used that term to refer to the health and welfare of African Americans in the United States, and said for years we have benignly neglected this population. The same is happening with migrants. We pretend they're not there, and I've just come back from a meeting yesterday in Stockholm where we were looking at screening for viral hepatitis, and then for some reason we went on to schistosomiasis too, but basically screening. And the reality is that screening today for a large part of the population of people on the move is not possible, because we don't know who they are. We don't know where they are. So this group of people that we call undocumented, illegal, irregular migrants is in fact a virtual reality. We don't know their names, we don't know their genders, we don't know their ages, we don't know where they're from, and certainly we do not know what their health profiles are. So I'm saying this simply because this picture that we're talking about, that I'm going to talk to you about, I just started and he's telling me I've got 5 minutes left. Peter, I mean, you pulled me out of my bed to come and now you're telling me I've only got 5 minutes? Yeah. All right, let's move on quickly. So that's just to give you an image of how many, let's say there are a lot of people, all right? Go ahead. Now, this picture simply to highlight the fact that we are not talking about a homogeneous population. It's a very heterogeneous population, and this is a group that you need to pay a lot of attention to, these two groups here. Because we forget that in the UK, 40% of the healthcare personnel is foreign born. And that a few years ago, the Norwegian Ministry of Health calculated that over the next 25 years, it would need something like, I think, 15,000 new, 150,000 healthcare workers, doctors, nurses, technicians, and so on, and accepted that 80% of that population would necessarily come from abroad. Now, I say that simply because today Norway began erecting its first anti-migrant fence. So we live in a world of contradictions, and that is the main contradiction that we have. So please go. Now, what I want to draw your attention to specifically are these two ladies. At the hospital, cantonal hospital here in Geneva. So the lady on the left is having a wonderful discussion with the physician on what she must do to manage her diabetes, her type 2 diabetes. And you can see from that image what a wonderful interaction they're having. So he's actually almost touching this lady that he anywhere else in the world he wouldn't dare touch, and she's laughing with him. Let's go out and have coffee, right? So after this session, we take them apart and we say to him, how did it go? He says, really, really good. This was a good interaction. We ask her, oh, it was wonderful. This doctor is so nice. He smiles, he jokes, he laughs, and so on. And then we say, so now you're going to go on and you're going to measure your glucose level. And she looks at it and she says, what? And she's not understood anything. So I raise this because this is one part of the health literacy challenge. The other lady is sitting there at a reception being received by someone who is wearing a white coat but has no training in health, who has not been given any responsibility to do a triage, but who is looking at this lady and is basically saying, what the hell are you doing here? Should you be here? So that lady, she doesn't, but in many instances, people in that situation just get up and leave. So here we have two aspects. You can go to the next one. So here we have people talking cross purposes, and here we have someone who's simply lost in the system. So this is one aspect of the health literacy challenge for 224 million people around the world. In Europe, something like 80 million people, and growing very fast. So this is a daily occurrence. So you can move on now, because I think I've said everything I had to say. Good. So poor health literacy, what are the implications of this? Well, poor diagnosis. Those of you who want to understand what this means, look at the data on schizophrenia in Europe. Look at the data on schizophrenia in Germany. Something like 80% of all diagnoses of schizophrenia involve migrants. Insurance companies have questioned this and at times have actually requested second opinions. And the second opinion says, bullshit, this is not schizophrenia. This is just somebody that didn't communicate well with the doctor. And schizophrenia has become that waste bin. And schizophrenia, the diagnosis of schizophrenia is terrible. In terms of medication, in terms of what the family believes, in terms of what your employer thinks, in terms of whether you stay in school or not. So schizophrenia is really a killer. And it is the basket of poor health literacy. Inappropriate treatment, so I've diagnosed you with schizophrenia and I put you on some schizophrenia related medication that's basically going to make you a zombie. Yeah. When in fact you could be working, contributing, running a normal family life. And I'm using the schizophrenia example simply because it's it is a very dramatic one. So when we say low satisfaction, who's low satisfaction? Well, the physician comes out saying, Jesus, that was a difficult one, you know. I hope I don't get another one like that. The patient says, am I really schizophrenic? And the patient's family says, who is this psychiatrist? Doesn't know shit about it, you know. So the poor diagnosis leads to low satisfaction, which is a major problem today in our healthcare system, everywhere. On the right-hand side, you get the inappropriate treatment, and then you get low satisfaction as well, because sooner or later you're going to realize you shouldn't be on aspirin. And then, of course, you get this phenomenon of poor adherence. Now, Elizabeth is working on diabetes and is constantly aware of the main problem in diabetes care is that people don't take their treatment. Now, why don't they take their treatment? In many cases, because they don't understand why they should. They don't know why they should be exercising. They don't know why they should be changing their diet. They don't know why they should be responding to glucose measurements or even taking glucose measurements at the time that they should be. There's a complex of issues there. So poor adherence is a major problem in diabetes and any chronic care. Any chronic care, including, by the way, HIV, which in a way has become a chronic disease because of the long-term therapy that's associated with it. But we also know from data that we also get very, very long rehabilitation modalities in migrants who have had, for example, accidents or surgical operations and so on, simply because the follow-up with migrants in post-surgery or post-trauma cases is not adapted to the nature of the migrant. Bert's probably more aware of this than I am, but 2 years ago there was a case in Geneva of a woman who tried to sue the Department of Obstetrics because she said that there had been a too early, a precocious intervention. So she'd been given a C-section, and she said this had happened too early, without discussion, and so on. It turns out she'd been in labour for something like 15 hours. It was going to be a terrible delivery. They didn't say it, but the reality was that she'd been infibulated. They didn't know how to do a vaginal delivery with an infibulated woman, probably couldn't have done it. A Somali woman who said later that it was appropriate to go into a long, difficult delivery. So then you get the whole concept of pain associated with lifetime events and the expectation that nothing happens really unless you have that sensation of having given. Which in the West, of course, you know, we would do an anesthetic for a headache, you know, we do. And then of course there's the major problem of disease resistance that's emerging in the area of TB, that's emerging in the area of HIV now, that's emerging in the area of any place, any type of treatment where the poor adherence leads to mutations. And then of course the key issue, because we will always push this theme with insurance companies, is the very elevated socioeconomic cost. All along this sequence of events, you have people who are out of work, you have people who are going to the wrong department in the hospital, you have people who are going to the emergency ward when they should be going to a permanent or general practitioner. There are people who are not taking the treatments that are prescribed properly, and hence coming up with secondary infections or secondary problems. So the cost is huge. And I think health literacy, the promotion of health literacy, must think about making healthcare a much more rational process than what we have today. Since Peter only allows me 5 minutes, I could go on. I've got a lot of other stuff, but we could stop there and have a discussion. Simply to say that we are mounting a new initiative on health literacy for migrants. And we're going to be doing it in Germany, Portugal, Spain, and the UK as a first phase. So we're setting up this project, and hopefully by the end of this year it will be up and running. And we're going to use it primarily as a rapid project, as a demonstration project to highlight A, that there is a need, B, that we can gather data in this population, including this virtual population of irregular migrants, and that thirdly, we can actually develop initiatives, and Bert and I were talking about this earlier, which are based on training people from within migrant populations themselves. Good. So
we will have a panel discussion, but I will allow for a couple of questions or remarks before we move on to our next speaker who has arrived. Any
Ilona, you mean that I have to go quickly because of you?
No. Diane.
I thought you had opened the day, so I'm totally mixed up about
I didn't wake up this morning, so I couldn't get here on time.
Yeah. Diane?
Thank you so much. I think it was a wonderful overview of so many issues that have to do with intercultural health literacy and migrant health literacy. I just wanted to comment on some experience, a very vast experience we have in Israel with immigration and migration, that often because of the misunderstanding and the mistrust, I would say, many people will not take medication and will not apply care because they assume that their provider didn't understand them. So sometimes the adherence issue is just an issue of trust, and there's a lot of consultation in the community after they've had one consultation with their provider. So it from our experience, it initiates a whole wave of communication in the community when one person has gone to one provider. There's a lot that goes on with that interaction, and so I think that's a very complex issue.
Yeah, and Diana, I think the thing that comes to mind immediately, you talk about that. I did some work long before you were born with Judith Schuval, who wrote.
I was born, I promise you.
Who wrote.
She was a colleague of mine.
When she wrote On the Threshold.
Yes.
And the issue is not that one patient loses trust, but goes and says to somebody else, man, I wouldn't trust that guy. You know, he doesn't listen to me. We did a study for the Canton of Geneva, for the city of Geneva, a few years ago, on social insertion and access to health care. The main problem that emerged in that study was patients who said, nobody listens to us. Nobody is interested in our, what do you call it, our journey. Not the physical journey, but the conceptual journey. No one cares where, you know. Meanwhile, the doctors and nurses who were part of that same study are going to class at night to learn about these people's journey. So somewhere in this interaction,
the link was missing.
There was no link. Yeah, two people like this lady up here, totally committed, totally concerned, but not communicating in a way that generated the trust that we're talking about.
Thank you, Jörg. I have one more comment, and then we'll have a panel discussion after the one.
Thank you so much, very impressive. It reminds me of the project we did on migrant-friendly hospitals, where one of the important things was as well to improve cultural competency of staff, and that can be done only together with the clients.
Yes.
And the other thing is, migrant health is really a big challenge for what is called now health literate organizations. And I think in health literate organizations, therefore, the second principle that we have is to participate with your users and to make this institution more user-friendly, but that you only can do together with the users. And you need to include the users in everything you do, in your processes and into your materials and everything. Therefore, thank you so much. And as we all know, the problem is becoming bigger.
And I'd love to hear more about the health literate organizations.
Yeah, we will take that for the panel discussion. Now it is my pleasure to introduce to Ilona Kibush. Although you were not present in the morning, you were present online. I noticed that. So when we launched the website and our association, and we were lighting our candle, which will go on to the US next week and go to Vietnam in November, and then we have been around the world launching Shanghai. We can bring it to Shanghai. Our candle, our light, and hope for the future. Ilona Kibush is, I would say, one of the mothers of health literacy. And last night we were discussing, is this now with the new association the second, third or fourth wave of health literacy? You can perhaps tell us looking back, but we also asked you today to provide your vision and your ideas on how we can step up on health literacy and have it even improved on the global agenda.
Thanks very much, and great to be here. Great to see old and new friends of health literacy. Do I need to be a
You're
video?
good right
No?
there.
Good. That's
She's good.
Yeah, we are live streaming. So
yeah. So I thought I'd stand here.
Yeah.
So I have focused on what you asked me to talk about, and thank you again for shifting the program around. I arrived at home very late last night, so I could sleep a little bit at least before taking the train again. So this has been much appreciated by me. In terms of one or two issues around the history, there were two people who were really, I would say, in love with the notion of health literacy at the end of the 1990s. That was Don Nutbeam on the one hand and me on the other hand. At that time I was in the United States and Don in Australia. And for me, health literacy became tangible not because of the work done on health literacy, which I only found out about later by Ruth Parker and others, but because of work I read from California on environmental literacy. And I found that so interesting, environmental and later then ecological literacy, that I thought, well, you know, in terms of health promotion, this is actually what we should be talking about. And I wish, I thought, we had that term when we were writing the Ottawa Charter. We didn't yet have it, but now we do, and I think that makes a tremendous difference, and I'll come back to that. Actually, Dawn and I tried to integrate that term, health literacy, into one of the declarations. I forget now whether it was Bangkok or Jakarta, one of the health promotion conferences, obviously, and it wasn't accepted because people said already we have so many new terms, etc., and we will just work through health education to health promotion. If you're now coming along with health literacy, it complicates everything. So it took some growing time, and Don, of course, has contributed many very, very basic articles on that with his 3 types, etc. I have pushed more the political side and tried to gain political support for health literacy. I've not really done health literacy research myself, but I felt I could be a very good advocate. And partly I was successful because I came back from the United States and went for the first time to Barkestein and met some people from the European Union and said, guys, you need a European health literacy survey. It then took a couple of years and some very active people, including particularly Helmut Brandt, who knew how to write complicated applications to the European Union, which only very few people have the literacy to do. And he was successful, and the rest of the story you know. And now with Christine, we're coming here.
Yeah.
So that's a very, very short version, and we can talk about some of it more. And I'm of course very, very, very happy about that, and I'll continue to try and look at you, but I do have to look at my notes now.
Because Arby will do the slides for you.
Oh,
so
you can't do this. Okay, all right.
That's fine.
First slide, please. So obviously this is part of the story. I already said I wish we'd had the term health literacy at the time, and we have that tradition to build on, but where I think we have a tremendous opportunity is through the Sustainable Development Goals. And many of the challenges there, because as I'll also say, health literacy can also work as an integrative concept between many different areas of health determinants. We know health literacy itself is a health determinant, but it interacts with other health determinants. Migration is a health determinant. And I think some of the work we should continue to do on health literacy is that interface of determinants. With that, we could give a very great contribution to the Sustainable Development Goals. This is the picture that WHO uses when it talks about the Sustainable Development Goals. WHO is smiling. And they have put, I call this the soup plate of SDGs and health. But what they have done very cleverly, and I think we could do something similar with health literacy, is to put the health goal in the center, all the other goals around, and then in the middle they have what health contributes to the other goals. Of course, there are also drawings that show what other goals contribute to health, so you get that dynamic. But I think we can learn from this, and I'll show another picture later on. Next one, please. What's very important for us, since we come out of the health promotion family, even though it's not sufficient, again, I'll speak 2-3 things about that, is that there is the 30th anniversary of the Ottawa Charter this year. And on occasion of that, and occasion of the G20 of China, the People's Republic, there is the big conference on health promotion. And you can see that the declaration and the conference have 3 key areas, and would you believe it, one is health literacy. That's an incredible support for anything this association might want to do. I'm partially involved in writing the declaration from this conference. It of course goes through a lot of political process and everything, and somebody sort of got to try and tie that together. So I've been asked to join that group. But I think this is an important message. After Shanghai, there will be a strong political statement from the World Health Organization in support of health literacy, and that relates to another one of the strategic points I'll be making. But already you see here, health literacy relates to the other two as well, because contribution of cities and communities, the health literacy of cities are becoming ever more important actors in global health. And of course we want community health literacy, not only individual health literacy. So again, I think there's that interface, and in my view, ensuring the health literacy of your population is one defining component of good governance for health. So again, I would urge us, just like we had that Ottawa drawing, don't just look at that health literacy chunk of what comes out of Shanghai, but the interface between that, and Fatem will be able to probably say more about that, how that process is going on. So the next slide, please. So obviously our health literacy work must build on this notion of where health is created, where people make choices for everyday life. And you can see we actually expanded this definition a little bit. We added, for people of all ages, live, love, work, shop, and play. Because the commercial determinants of health, because people live in a consumer society, because of NCDs, this is an issue again that we weren't strong enough yet in the Ottawa Charter, and it's absolutely critical for health literacy. So I've put together 8 points for the strategy. First point, please, I hope. No, last point of introduction. I have not put up a definition of health literacy. There are many, there's your wonderful one, there's one I suggested, there are others, but I think, at least for the strategy, for moving into the political arena, let's be pragmatic. Let's, there are good academic definitions that cover everything, but depending on your culture, depending on your context, try not to be perfect. Try to use a health literacy definition that is attractive to people you want to work with, that politicians can understand, that helps you move the field forward. Next slide. Message 1. So the message we always have to bring home as we are strategically moving forward with health literacy is health literacy can be measured. It's an outcome measure, it's not an input. It needs inputs, yeah, but we can measure it. And the political power of this concept is that it can be measured. We have success we can build on that's been going on for 20 years now, the Health Behavior in School Children study, and actually they're starting to integrate health literacy measures. Lasse Canas just told us about that. But this fact, in any kind of advocacy, this has to be highlighted. We can measure this thing. Again, there are different ways of measuring it and whatever, and academics can fight about it. But, let's try and find a consensus like the HBSC, where there's a certain amount of comparability globally, and then we can move forward. Next message. Message 2, that means political relevance. Colleagues here in the room that were involved in the European study saw suddenly, when you, as a policymaker in health, saw that you were on the bottom of the league table, you started getting active. Switzerland is really nervous. They just did a health literacy survey and they found out they were doing as badly as Austria. My God, who wants that?
Nearly as badly as Bulgaria.
Yes.
No.
So this is scary for politicians if people start talking about it. That's why we need comparability. So again, even if from a scientific perspective, some of these measures aren't perfect, the fact is they allow us to make a point. And they say more than just, the literacy of one person or one community. It's like an index. It's like the gross national product where countries compare themselves. And this is the index we were always hoping for. And of course, these indices, you can build them anywhere. As I said, you can compare cities, you can compare communities in cities, you can compare anything where there is the political will for comparison. So go out and look for people who want to compare. Small, big, regional, local, and compare. Do it. Go to the mayor and say, don't you want to know how the health literacy in your various parts of the city compare, and then relate it to the use of the emergency department of your hospitals. Things like that. Be very pragmatic and use it. It enables comparison. Most important message. Third message. Low health literacy endangers us all. And there's a difference here to some of the arguments we've used earlier. Now, I'm not saying, go around and scare the hell out of people, but sometimes you should. And one of the things I'm preaching about right now is don't only look at health literacy in terms of non-communicable diseases. That's partly our tradition, that's fine. We've added, I'll come to that, the health systems literacy. But one of the greatest challenges in the world right now is antimicrobial resistance. If we from the health literacy community do not contribute and are able to give information and use the data that other people have gathered, what people know about using antimicrobials, so that's one of the areas. The other is obviously vaccines, and here in Europe we have a big anti-vaccine movement. So there are issues that traditionally health promoters would have left to one side. Infectious disease. We cannot make that separation anymore. And health literacy surveys also, if they want to be internationally comparable, have to deal with all issues relevant to global health. Because so far, I think the instrument was, of course, written for Europe, but we'll have to see how must one tweak that instrument. What do other countries that are at a different level of development, what will they need to add? So that for me is very important, and of course, the environmental issue. And that, and all these things that I'm saying, that shows you who you can build alliances with. Just one of the new things that's been created is an alliance for antimicrobial resistance. That's health literacy people should be there. So you take every one of those issues and say, my God, who's strong here? And you go there and you say, hey guys, I have something that can be useful to you. So the thing is not just to have your own alliance, which is absolutely critical, because you need to build the field, you need to build excellence, but the issue is really, who's on the way up, who's strong, what are the issues out there, and then say, hey guys, I've got a solution for you, I've got something that can help you make your point. Absolutely critical. Fourth issue, I've already hinted at it, health systems literacy is critical in a health society. And you've made some of the economic arguments, very, very rightly so. And we need to make them, but at the same time, we need to underline this is an issue of patient rights. Systems literacy is an issue of patient rights. People have a right to know how their health system functions, what it costs, what their rights are within that system. And it's not the case. They need to know how it's financed, health insurances, the whole gambit. And this, of course, gives you, again, alliance with patient organizations. Get strong patient organizations on board. For them, health literacy is critical. So, I could outline this in greater detail, but I'm not allowed, so I won't. My fifth point is linked to other literacies. You've discussed this in various ways. Of course, there's basic literacy. It's very clear to us. I think two are absolutely critical, and again they give fantastic alliance possibilities. One is science literacy. People just don't understand things. Take antimicrobial resistance. And when I say people and science literacy, I also mean politicians. You know, we're not just talking about the general public. We're talking about the health literacy of political decision makers, and we're talking about the health literacy of many health professionals who are also not as health literate in certain areas as we might wish. So again, we always have to think that triangle, the professional literacy, the people's literacy, and the political literacy. And digital literacy is of course absolutely critical. More and more of health literacy is going to go through that channel in one way, for good and for bad, and therefore, you know, we need to build alliances there with people who are moving that forward. And that raises the issue of the private sector and things like that, which we might discuss in the panel. Next message, message 6, obviously build on the settings approach. Jürgen Pelikan's already mentioned it. A tremendous possibility of health literate organizations. We have a global network on health promoting hospitals. They need to become health literate hospitals. Partly they have, but you know, it can become much stronger. We've got a healthy cities, we've got a health promoting schools movement out there. Build alliances for health literacy. Tell them, compare yourself, compare yourself, compare yourself. Remember my message too. And definitely I'm bringing this message into the Healthy Cities movement in Europe and saying, you know, let's compare the health literacy levels of the cities in the program. Message 7. No, this is just a picture I promised you. This is where they've put a school in the middle and put all the other sustainable development goals around it. So, you know, it's a sort of game, but it helps. Yeah. Don't make me so nervous. Message 7, I've already said it, includes consumer settings. We have done a lot on the NCD agenda, but not enough in terms of consumer settings, not enough in terms of commercial determinants of health. And that, of course, means issues of labeling. You know, how can you be an informed consumer, as some people call it, but you know, how can you really make choices? And you know, it's not just people with low levels of literacy. You know, I sometimes stand there and say, my God, you know, what's the salt level in this thing? You just can't read it. You can't interpret it. And therefore, we need to build alliances with the people who want labeling, with the people who want traffic lights or whatever, with the people who are working on the sugar tax. That's where we should be. Not, you know, in a small health promotion or health literacy community. And again, the rights issue is critical here. It's all about consumer rights. Message 8. That is my last message, and I think I'm keeping my tie. Send a strong political message beyond the tool. So we have health literacy, we have the tool of comparative surveys, compare. But we have to say, guys, this is more. This is about more. And that's where our health promotion tradition comes back in. And that is something that allows yet another type of alliances. This is where we can align with human rights people. This is where we can align with people who are interested in empowerment, citizenship, and democratization. Because a patient has the right to all information, and not just the right to information, but the right to understand that information. And that is the difference between, you know, this notion of the informed patient, the informed consumer. Here we'll give you something, be informed. And we've heard from Manuel, you know, there's many people, there's the migrants, there's people who are mobile for other reasons, there's gender differences, there's all kinds of stuff. And the things are just not relevant, understandable. So there's a right here. It's part of empowerment, if you're empowered to make your own choices, your own decisions. And for me, in the 21st century, where we're in a knowledge society and a health society, it's a right of citizenship. If 10 to 15% of our gross national product goes into health, then the users and the patients of that system need to be literate to use that system well. and that it serves them well. And that relates to the last point also raised by Jürgen. It's about co-production, it's about the democratization of the health system, it's that the patients and the citizens contribute and the professionals contribute, and that the system is amenable to empowerment and to rights and health literacy. Thank you.
I'm happy that you're mentioning to stay here for a few questions, the definition and the tools, because from our European group, you mentioned we reviewed the definitions, we found 17, but actually in our understanding they were so overlapping and only a few things differed, and therefore we made our all-inclusive definition to ensure that for at least the instrument we will cover everything.
Absolutely.
Unfortunately, how it has been interpreted later on is that there are 17 different definitions, therefore we don't agree. And that is a shame, because of course they're so overlapping. We are talking about access to information, understanding, appraising, having this critical reflection, and being able to use it, ability to act. So that would be my one.
I love your definition. The fact is, it's too long.
Yeah, but it's for the quality. It's an academic definition for that research purpose of the development. Every time I am going to the EU or other meetings, I often use yours or the American from the WHO, the short ones. Definitely, I fully want to support you in that message. Choose the one that fits the purpose, because they are so overlapping. We are talking about the same thing.
Absolutely.
And the same with the tools. It has been, I would say, dominating the discussions in the field for a long time. We now know one of our colleagues in the United States, he has made the tool shed. There are more than 130 tools, he informed me last year. So there will not be one tool. You have again to choose the right tool for the right purpose in an academic way. And there are so many options.
Yeah, but we want one tool that we all use, like the health behavior
for the comparison.
study.
But there are some that are now being used to compare. Well, let me open up the floor for some comments.
Yes, thank you very much for your presentation. Very, very stimulating. And you talk about alliance, and I think that in this kind of alliance, there are two sectors or two disciplines or two, I don't know how to mention, that can be very useful for health literacy promotion. One is the tactic of science. It is, this is a field where I work in, because many people around the world, how to teach science and how to analyze the learning problems and the understanding problems of the population, and the results are very similar in fact. People in general, this is the result of research, don't know basic knowledge, have not basic knowledge about health. The other sector that can be very useful is intercultural education. This is how to deal with the differences, the cultural differences between the population or the pupil you want, or the patient, and the teacher or the doctor or the social worker. But there are also another concern that you talk about, to mention, and I suppose that it is very, very important, is that the diffidence of the population, or part of the population, concerning medicine and concerning science. People, many people, are using today parallel medicines, flowers of Bach, homeopathy, etc., 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 and are not going to medical doctors and not following the treatment, and this is not low literacy people, are high-level people, university people. Now, this diffidence against science and against medicine is probably one of the factors that you mentioned, vaccination, etc. It means that health literacy should not be only to transmit information, but to change attitudes. It is to change the attitudes of the population, or part of the population, concerning science, concerning medicine. People should accept that knowledge exists and should change in some way their negative attitude.
you want to respond?
Well, I just think, yes, of course, I mean, your first points very much are about the other academic disciplines and knowledge, etc., that one should pull in as one is further developing health literacy. I think the health literacy experts here would say that health literacy is never just about information. It's about motivation, it's about taking decisions, it's about attitudes, obviously. Those things are pushed in that way. So yes, I can only agree. And again, one of your points is also interesting, that some of these problems that I've mentioned are not a question of low general literacy. I think that's a defining factor in our societies, and that is something we must deal with. So it's also not always a lack of knowledge, it's a decision. It's not trusting that knowledge. And therefore there's a lot that we have to think about and develop further.
We have two questions from the
Two questions from
our live stream.
From our viewers. One question is how to make health literacy understandable for policymakers in order to make system level changes. What does one do? How does one make health literacy understandable to policymakers to make system level changes?
Well, it depends on your policymaker. I mean, policymakers have different values, different attitudes. They're in different political systems and cultures. Some policymakers, the economic argument holds very strongly, and that's what's been used particularly in the United States and Anglo-Saxon countries very much. In other countries, for example, where we have national health systems, etc., the economic argument sometimes doesn't catch that much. It's other welfare arguments, it's arguments of rights, etc. So I think, also making clear how important health literacy is, that it is a determinant of health. It's not just, some strange outcome that we have somewhere. It's a determinant of health. So politics is always very context specific, and that means before you go and talk to any politician, study the politician, find out what she or he is interested in, and then adapt your health literacy message.
And the second question, what is the best practice / methods to gather a comprehensive health literacy profile for an individual or group of individuals?
I leave that to the academics to answer afterwards.
We're working on that. We will bring it to our agenda. I would like to move on to Diane, and then keep your questions for the panel discussion afterwards. Thank you, Nina, Diane Levin is here representing also the International Union of the Health Promotion and Education, where you are leading the global working group. And we are very sure that we can help each other now from the International Health Literacy Association and the work that is being done within the field of health promotion. Thank you.
Thank you. Thank you all so much. Thank you, Sabrina. Thank you, Peter. Thank you, Christine, for putting this meeting together. I love the metaphor of the candle. There's a beautiful saying that says a candle can light 1,000 other candles without shortening the life of the candle itself. So I think it's a beautiful metaphor for the IHLA. So thank you. Yes, my name is Diane. I have several hats. I'm proud to be the director of the National Department of Health Education and Promotion for Clalit Health Services. It's Israel's largest health service organization. It's the second largest non-governmental health service organization in the world. Little country, big organization. And I'm an assistant professor of health education, assistant professor of public health in the School of Public Health and University of Haifa. It's the first time there's been an appointment of an academic for health literacy. And as Christine mentioned, several of us together here founded Jürgen and Jill and Christine and Peter and others who founded the Global Working Group on Health Literacy from the International Union of Health Education and Promotion. And so just maybe one or two slides just about that, because people have asked about that. So if you could, and thank you, Arvi, for being the wizard for our pushing the slides, and if you want me to go faster, just push the slides faster. Okay?
Or you do
and there we go. Okay, so let's go. So the International Union of Health Education and Promotion was established in 2009, a global working group of people coming from different aspects of health promotion. And in Geneva, exactly. And in Geneva, at the global conference, we actually established it. We have a mission statement and we have terms of reference. In the next slide, you'll see them. And what we established then was very similar to what IHLA is looking at now. So if you can go to the next slide. And the mission statement is to initiate, to support action, policy, research. And we acknowledge the contribution of health literacy to reducing disparities of health, well-being, sustainable development. This was in 2009. We weren't visionaries, but we believed that that was true, and now we see that it's really, really important to the pursuit of equity within and between countries in the global context. This was more than 6 years ago. We're reviewing it as we speak these next few days, and we're actually not finding a whole lot that we really want to update here, but we're re-examining it. So you're all very much invited to join us. We have a website, and anybody during the coffee break or during the lunch can talk to any of us who are involved, and we'd like to see you all involved. So let's go ahead for the topic of the talk today. We'll be talking a little about e-health literacy, m-health literacy. It was mentioned digital health literacy, social media. We have so many terms for it, and I may be actually proposing more challenges and more questions than we have the answers for. And one of the reasons I'm going to do this is because I think we need a paradigm change. I don't think it's a niche or a specific aspect of health literacy. I think it's really becoming very pervasive. And I love the term of benign neglect. I'm concerned that there may be some benign neglect for the way in which health literacy is actually looking at e-health literacy, m-health literacy, m-health and e-health. I think it's more pervasive than what we maybe think, and we should be paying attention to it. I almost would say, and I think I'm not going to say almost, I propose that we look at it as a setting, a health promoting setting. So let's go. So we're going to hopefully do some definitions very briefly, and I want to have some examples of how we can see it as a two-faced debate. So let's go ahead and let's keep in mind that we're talking about health promotion, and that's where I come from. Specific aspects to take into account during maybe the next few minutes are empowerment, enablement, and social determinants of health. So, e-health, I'd like to take you to a few definitions, maybe historic definitions. History in e-health is not 100 years ago, it's not even 10 years ago, maybe a little bit more than 10 years, but it's been really moving fast. The initial definitions of e-health literacy, excuse my back, I'm sorry.
Nice back.
Thank you. I can walk around and go from side to side. And look at what the definition was in 2001. E-health as healthcare practice supported by electronic processes and communication. And look how the definition shifted to 2005 and beyond. We're seeing e-health as a set of technological themes in health today. More specifically based on commerce, here's that commercial debate we were talking about before, activities, stakeholders, outcomes, locations, and perspectives. If we compare the two and go beyond, we'll see how it really, there's a paradigm change of what e-health was. It grew out of healthcare system, and it continued on, as you will see, to really include many more stakeholders, including civil society. So in Europe alone, why are we talking about the scope of it? Why are we concerned? Even in Europe, I'm in Israel at the crossroads of Europe, Africa, Asia, but in Europe, and we see that $30 billion is invested in e-health tools. It's not a small amount. And there's 20% annual growth. That's huge. That means in 5 years it will double the market. And we have to pay attention to that. And if we go look at the forms of e-health, we're going to just click through this really quickly. Not that you have to read all of this, but just look at the different forms. And even in the next slide, almost all the forms of e-health came out of the healthcare system, whether it was e-health prescribing, whether it is for accessing healthcare, whether it's informatics. And just now that we're getting to look more closely at m-health, are we really seeing how it's in the hands of each and every one of us in a big way. So what is m-health? M-health involves the use and capitalization of mobile phones because it's really in all of our pockets for core utility of voice, short message services, applications, global positioning systems. This is how we're really going global, where we have to really pay close attention. And the next slide. So why mHealth? The number of subscriptions in 2013, I haven't seen a good survey since then, but the estimation was that there are 5 billion subscriptions. And how many people are there in the world? Look at the high percentage of subscriptions in the world compared to the population in the world. At least 85% of the globe is covered by commercial wireless signal. Just a couple of weeks ago, the satellite that was supposed to go up, the Amos 6 that burst, it was supposed to bring Facebook to Africa. So within 2 years, we assume that it's going to be able to be promoted again. So many low middle class and middle income countries, we're seeing penetration that's surpassing the infrastructure of roads, electricity. It's getting to people where other infrastructure aspects are not getting to people. Let's go ahead. And there's a great, I really recommend reading this report on mHealth by the WHO. There's a lot of good information. You can compare the countries, the penetration, the use, and a lot of good examples of how positively mHealth can be promoting health. So why are we concerned? Why am I concerned as a health promoter? Why am I concerned when I look at health globally, health promotion globally? We have a two-faced debate. And Arvi, you gave me a really good promo before because you mentioned it. Does E or mHealth widen or narrow the digital divide? And does E or mHealth is the trend providing more opportunities for people to promote their health, or is there more exclusion? And this is a question, of course, I'm not going to answer today. I don't think we have enough research to be able to answer it, but we really have to take a very close look at this. It's not a niche. It's really very center stage. Let's go ahead. So if I can also quote a study, we're seeing it's a lifelong course issue. 6-month-old babies are now using tablets and smartphones. We're seeing a study that says, it's a study that was actually published by the Pediatric Academic Societies, where by the age of 2, most kids have used a mobile device. More than 50% have used a mobile device. And it's something that we're seeing, where we can observe, but we're not really understanding what it's going to mean as far as health. Let's keep going. So, once a book was a book that you would hold, and the kids, and we maybe as kids all would read one book and talk about it. Now, the book is the Facebook, obviously, and that's really what is the topic of conversation, and it's the basis. It's not necessarily bringing people together. It also can be isolating. It's both. Let's go. And of course, it's global anywhere we go. So the pace is enormous. If I just look at my own institution, which has become, I come from Startup Nation. Israel has been coined as that phrase. Discon queue was, or the jump drive at USB was invented in Israel, and ICQ and many other initiatives, the IT initiatives. So in Clalit Health Services, we've been really promoting the use of websites and use of different mobile applications to be able to reach as many people as possible. We have over 5 million people who are in our institution or members of our institution. And just from January to August of this year, we saw a 15% increase of people looking at information. We're seeing 22% if we look at in addition to applications. We have apps that look at pregnancy, how is the baby developing. We see milestones for health, and people are becoming more and more interested in a bigger way. We're happy about that, but it's also concerning who's going into the apps, who's looking at the information, and how accessible we are to the rest of the population. If we can go ahead, we just launched last week telemedicine. It's a small country, and we're very accessible, but still, we want to make sure that people have access to healthcare even after the clinic hours are closed. So now you can contact a dermatologist from 7 at night to midnight after the clinics are closed. And if you have a rash, if your baby has a diaper rash, if you have something of concern, you can go online, and there's a video conference with a dermatologist who will actually see what you want to show them. And this is just a week old, so we don't know how far it's grown, but there's a lot of, I would say, maybe positive, exciting things about it, because it isn't necessarily a language barrier. But we're going to learn more about how these things progress. Let's keep going. We have our online services are in Hebrew and Arabic, Russian, French, Portuguese. We also have information prescriptions. If you want to go to your doctor and he clicks in a diagnosis for you in your medical record, your electronic medical record, firstly, you have access to that from your home, and secondly, you immediately get an information prescription to your house. By the time you get home, you have an email from your doctor giving you more, hopefully, appropriate information about the health issue that you came to visit him for or her for. What's going on with sensors? We're saying it's e-health, and we're going right into e-health literacy right here. There is almost no barrier between e-health and e-health literacy because information that people get about their health is relevant information for health promotion. If people understand it, if people use it. Whose information is it? We're talking about the big data questions. Who's going to be accessing it? Do we have the rights to our information? Do we have rights to security of the information? So let's keep going on this. What are the advantages? Of course, it depends who you're asking. It overcomes distances, it overcomes language barriers. We're conveying real-time information. It can hopefully help promote the patient-provider barriers. It can expedite navigation of the health services, and it can be cost-effective. The question is, what do we define as effective? So it also offers anonymity. Some people want to be anonymous. Some people want to access information when they don't have to face their provider because there is some question about distance, about embarrassment, about cultural barriers, and sometimes your provider is also your friend. So maybe you want to ask some anonymous questions. This is just a little bit of humor. But we do see some good health outcomes. There's some very good studies that have shown that through SMS texting, there's smoking cessation diabetes programs, smoking cessation programs, diabetes self-management, weight loss, immunization, the question that Ilona brought up about vaccines. We're seeing more and more information and more initiatives on health literacy and e-health. So if we keep going, there are barriers, not just advantages, there are lots of barriers. We have privacy, we have usability, accessibility, common language, and credibility. The issue of trust that's come up in so many of the topics, so many of the presentations this morning. There are issues of credibility, and I think that's positive because we're looking at critical health literacy. We have to help people understand that there's a good source of health information, there's questionable source of information. Why does someone want to access my attention? What is their motivation? So we're also looking at social media. I would like to propose our discussion about seeing it as a health promoting setting. It's where people live, love, work, shop, and play. And I think that we're actually surfing as well. So let's keep going.
I actually have one where I have Google as well, where
Okay.
people shop, Google, and play.
Okay, there you go. So we're not going to talk about definitions, so let's go on. Taking back consideration, and as Jürgen presented, we have Ruth Parker's display of where health literacy is the meeting of the demands of the system and the skills. What is happening with the demands of the system means you have to be more digitally literate. What does that mean? Are we including or are we excluding? So let's keep going on this. And actually, I'm again repeating and mentioning the health literacy typology of functional, interactive, and critical health literacy dialogue beams, and particularly one more click, I'd like to look at the critical health literacy. I think if we're talking about e-health literacy, digital health literacy, we have to really, really focus on critical health literacy so people can be really aware of what are the sources of information, what is someone's interest in me understanding the information they're giving me digitally. So let's keep going. There is an e-health definition. Many of you know this. It's from Skinner and Norman. It's from 2006. That is a long time ago in digital history. And I think it's really important we look at it, but I also think we have to revisit, and I think we also have to think about maybe an updated definition. It is about appraising health information, but what is health information now is not what it was then. A sensor, when I get an information about how many steps I've walked, that's health information. That is something that I have to understand. What does that mean? Does it mean if I've done 200 steps, does it mean anything? If it's 10,000 steps, does it mean more or less? And what does it mean for my health? So the next is, let's keep going. And I just want to mention the Korean conference that Ilona initiated that dealt with this very strongly. It was called The Power of Patients 3.0, and it was very central to the whole discussion on health literacy. We know that people look at health literacy, look at health information. Their sources are multiple sources. There's personal sources, there's media sources, there's internet sources. We saw that with youth, and we also saw it in different health topics. We're seeing it in Israel, and we see that people are really, the HBSC study that Ilona mentioned, Israeli youth are almost unchallenged as far as how many hours they're spending a day next to the screen. So whole issue of screen time replacing more health promoting physical activity is another issue for digital health literacy. And we're also looking, if you go back to this, we're looking at the critical health literacy, we're looking at advertising. What are people being offered? Look at this cynical example of, and I have nothing against Pop-Tarts. As a child, I grew up on Pop-Tarts, but we're looking at how the commercial system is using our health our health promoting messages to promote chocolate. Okay, so it's really a double-edged sword. Let's keep going. And we developed a media health literacy definition, and it was actually its own pyramid, but there's statistically became a pyramid of identifying, aware, critical action, and action for health literacy for media. And the results showed it is a social gradient, as we saw also at HLS in Israel, the HLS, which is really, it's published this week, the HLS EU study in Israel. So we're seeing social gradients, whether it's media health literacy or general health literacy. And finally, this was published in 2011. And there are measures, there's maybe one or two measures for e-health literacy. We have to look at them again, looking at now what we're doing digitally for health and redefine the measures. And finally, is it related to age? When many people associate e-health and e-health literacy with the younger population, it's not so. We're seeing the largest growing population of elderly and older people to be able to keep social contacts. And look how the changes come from 2011 to 2013 in the US and beyond. And Angela Liu, our close colleague in Hong Kong, also mentioned that the elderly, as though they are going more and more online, they're looking to face-to-face communication. So just to conclude, we're seeing e-health literacy being studied in different populations, parents, college students, people with special needs, and we're seeing the effects of it. Let's keep going just to the end. There are new frontiers, the e-wearables. Beware of what it's going to mean for health literacy. There is a case for action, and so to conclude, we have future challenges. What's going to be the significance of e-health in the life course? It's got to be center stage. It's not a niche. Are we talking about empowering or promoting passivity? Are we talking about the big data? Who's going to own the data? How are people's data from e-health literacy, from e-health going to be owned by people or owned by the systems or owned by the commercial companies? And how can the health promoting settings approach be applied to e-health and e-health literacy? So just to thank you, I want to make sure that we also make sure that we have the ethical considerations. If we're doing research, how we recruit people on e-health is different than how we do it face-to-face in communities, informed consent, and we want to make sure that the tools, the key approaches to approaching people with low literacy, we're not only talking about low literacy or disadvantaged or vulnerable populations, as Rob said, we're talking about everybody, and we have to be cautious. It is replacing other health promoting activity, and we have to make sure that it's all joined up. So in the end, if we're in a French-speaking country, I think it's nice to quote Jean-Paul Sartre, who said it was, to name it is to give it life. We've named it, we're giving it life, we're giving it content, and we're giving it data, research, comparing, and hopefully promoting.
Thank
you.
Before I open the floor for remarks to Diane, I would ask to Manuel and Joanne and Jürgen and Ilona to come up and sit here for our panel discussion to finish this morning's session up. And we need an extra chair. Perhaps to, yeah.
And lunch is here, but I think we take 15 minutes now for we're doing go 15 minutes into lunch, I know, but I think we can do it.
Have a working lunch?
Yes, then they have
Just bring the sandwiches in.
Yes, they're right, so we can get them and come in and
we're making a circle here.
Okay. Yeah.
So thank you, Diane, for your very fast-forward pushing us on the health literacy agenda. Are there any questions for Diane and her presentation?
For giving. In your presentation, I liked it very much, and you mentioned one problem that I think that it is a bigger problem, is how to educate people to select information. Because in internet we talk about health or diseases, and there are a lot of sites, and most of them, the majority of them, are wrong, are not scientific.
Yes.
Now, the problem is that the person who is using the system don't know how to select and educating people about how to choose in these millions or hundreds or thousands, I suppose that it is very important. I don't know if someone of you are doing this, but this is a key problem for me.
Yeah,
Because it's the paradigm of informatic system.
Yes. We've just finished a campaign called Promoting E-Health for Your Family, in the families of the new age. And one of the major messages that we have is actually helping young families in particular to learn how to access information that's appropriate for our family. What's appropriate for my family might not be for your family. We're looking at language accessibility as well. Israel is a very multicultural society, and we're very happy and we're very pleased, and we know we have to do more, because we all have to do more for providing the Arab population with reliable health information that we can back scientifically and socially, etc. And so it is a question of accessibility, it's a question of context, and it's also a question of understanding what the sources are. We don't come and say that there are bad sources of information, but we're trying to say, look at who is pushing the information and what is their interest. Is my health in their interest, or is it not? Is it their sales? Is it their commercial interest? Look at the fine line. And another important point is, look at the last time the screen was updated. What was the date? Was it 2009 or 2016? So there's a lot of really important points, very specific points we can help people understand.
Joanne, you would like to comment?
Thank you. I was really interested in the idea of information prescriptions. As a physician, that seems to me great. In fact, I key in my diagnosis when I see the patient, and I know they're getting information straight to their email box. But I have a little concern there might be an unintended consequence of that I might get a bit lazy as a clinician. I now know that I click on the box and they get the information, but I have no idea whether they then get home and understand that information and they're able to use it.
So I'll tell you how this really was
Short,
rooted in very short.
Yeah.
This grew out of a need that the physicians were saying. More and more people are coming to us after they went into the website and after they went into the internet, diagnosed themselves, one treatment that was written that was mentioned in the websites, and it's not what we think is appropriate. So we said, why don't we be proactive and bring information to them that we felt that was legitimate and that actually encourages a good dialogue with the provider. So what we always say is, ask your physician, ask your nurse, ask your dietitian about this point and see if it's appropriate for you. So we hope, and we have to research this. It's a point that we want to research. Is it promoting a dialogue, or is it actually giving legitimacy not to talk about it? So it's a great point.
Clinicians lazy.
We have a question from Peter
I have
Chen.
a very short one, and I'm very pleased that Ilona mentioned about the Sustainable Development Goals. And why we're talking about health literacy here? Because I'm thinking, because health expenditure is not going to expand continuously. It's not going to be sustainable. So therefore, health literacy is really making meaningful effectiveness and to make it sustainable for health services. I like to invite your comment on that.
We have a question from the internet.
Yes. How does one verify the information provided on e-health sources by healthcare providers to make sure that information is health literate for diverse target populations?
Huge question.
Can you give a short answer?
Short answer. Short answer. Yes, the short answer is that we really encourage people to say, if the information feels good to them about their health, then they can consult about it. And I don't think there's any one good source of information now for people for their health. People have to look at different sources, seeing how they converge, and to ask. I think there's a tremendous space for face-to-face consultations still. We're not replacing, the people that, as Charles Dickens said, the electronic communication will never replace people for face-to-face whose heart and soul are in communication. So it's not one replacing the other.
Jürgen, you have a comment?
Well, I had a comment to your question. I think we have to combine three strategies here. Of course, the one is to educate people to become more critical, but it's a very difficult and very long-term strategy. The other two strategies for me are to offer good quality information very accessibly. Yeah, and for example, NHS Direct or other things are ways to do that. And of course, the third, I think, is we have to fight bad quality information. Yeah, we have to campaigns and to show people what is bad. Yeah, we have to use that too, and to we have to try to certify what is going on. Yeah, and so therefore we have to combine the three.
Basically, much on the line that Jürgen has just said. Raul Gagliardi said that some people go to other healthcare systems, and when they do, this may be another type of health literacy. In other words, we have different health systems at work, and so we have to keep in mind that we are passing value judgments on different health systems, and we need to be much more culturally sensitive to that as well. But coming back to Diana's one of her slides, the chocolate triangle, which I love.
I know you're waiting for lunch.
We are in a very competitive system. At a time when electronic information is becoming most available, health is actually deteriorating. We have never seen obesity rates to the extent that we do today, or diabetes rates. So there is in a sense, there's a contradiction between the amount of information that is becoming available and the capacity of people to actually discern, to discriminate, and to use that information successfully. So we're in a competitive age. When we talk about health literacy, I think we have to take into account that we are competing against Nestle, against chocolate manufacturers. I mean, I'm saying that metaphorically, maybe we're not good, but the reality is that this is a competitive information age, and I think that we need to be much more, or at least the health literacy population group organization needs to be, I think, much more aggressive in defining its goals and defining the approaches that it takes.
I think we have to mention the issue of gaming also. If we had more time, we'd talk about gaming online. They're really trying to capture the attention of children also to be able to promote the products. If you go into some of the games, along the line you can click where there's a pizza, and then they'll show you where you can order a pizza that's closest to your home. It's that easy. So the commercial companies that you're talking about are understanding where to really bring the messages where people are enjoying their online time. So we have to be careful.
In fact, the health sector may be very behind in that.
I think it is. There is a question here. Yeah.
Okay, in addition of what you said, in Thailand 2 weeks ago, our ministry just announced that more than 50% of the information related to health that we share in the Facebook are wrong. And there are a lot of perception, like for example, anything rather miracles. People believe that it's alternative medicine, or what we call complementary medicine. So like people believe that if you drink soda is and with lime or lemons, it could cure cancer. And some of the patients took it, and one died because of like how you call this, rupture of the gastric like how you call it, stomachs, right? So that they claim like both sides attacking each other. So we don't know which one are right or wrong, and we don't know the intention because it's not come from any particular source, but it's circulate based on the goodwill. They thought that they believe that this is good, so we circulate and people take it. So what should we do in order to educate people? How could they select it? How could they kind of make a right decision on this one?
From the Sabrina, please.
I wanted to reiterate the concept of critical health literacy, which I really think is what makes the health literacy framework very different than a lot of other work that we do in terms of in terms of health. So to answer your question, if we can really raise critical health literacy, which I think is the core of health literacy in some ways, then people have those skills to be able to compare information and look at, discern, make their own decisions, because then they can see what is the information, what do other people say, what's the consensus, and because there's so much health information out there, and with the internet, it really makes it even more important. And just the other piece of part of the pie that I want to talk about is what Joe presented, and Jill, in terms of health literacy interventions at work, and what can we do as a field to support the health professionals doing very difficult work in terms of providing health information and health care to new immigrants, for example, a whole new population, in terms of accessing the healthcare system. So I know there's a lot of training, you presented training, but if you could talk a little bit more about health literate organizations and what we can do as a field to support health professionals and give them the skills and the resources to be more effective.
Perhaps Jill, you would like to respond?
So I think one of the key things here is just remembering what health organisations are there to do, and putting the patient, and I use the word patient if we're talking about health systems, the patient and their family at the centre of care. I think we need to measure what's going on, and we need to have as that measure what the patient and the family think about the health literacy of the organisation. So, and I think data is very important because it can drive change. I also think we need to have a culture change so that doctors, nurses, professionals providing services are open to the idea that actually if health literacy is improved, both the health literacy of the system and supporting the building of health literacy within patients and family, that actually that's better for everybody, and that it's not a threatening thing, and that everybody will benefit if the system improves. So I think those are the key
I think
things.
to add to that, I think the really important thing is raising awareness in the professional community that health literacy exists and what it means and why it's an issue. I mean, practically speaking, we talk about health literate organisations and environments. I have patients who fail to get their x-ray when I referred them for an x-ray because they turn up to the hospital and it says radiology and they don't understand that that's the same thing and they're too embarrassed to ask, and so they don't get their x-ray. It's really simple little things like that that I don't think that health professionals and health organisations as a whole are fully cognizant of, and just getting out there and raising the message, raising awareness.
Be more aggressive. We learn that.
Really help.
We have one question from the internet.
Yes, this one's not specifically at anyone, but in general, the question is, isn't health literacy more than just accessing information and focusing on where to get the information from? Shouldn't we focus on what people do with information in regards to health?
Yes. I would take the liberty to give the word to Ilona to finish off, because I know you had a comment and you could perhaps also link it to the question.
Well, I think some of us said this before, that yes, the difference of the health literacy concept is that it's not just health information, otherwise we'd call it health information. So it is about empowerment, it is about how you act, how you're motivated to act, how you make choices. So all those things become important, and therefore also, as another colleague said earlier, different disciplines become important because we have to understand better how people make choices. So even if they have all information, why do they make one choice rather than the other? And that makes it contextual. The other thing is that, of course, it's never enough to just focus on individuals. They live in an environment, and unless we build an environment in which their health choices are supported in many, many different ways, we will never get to where we should be, because we can't sort of repeat the old mistakes of health education. And there's a great danger that with a new term, people are just digging health education out of the graveyard. And the third thing, I think we do need to understand where some of the issues we face, and that's why I raised my hand, are linked to larger societal challenges we have right now. we're in a society where people have lost trust. And all the media you've spoken about actually have helped contribute to that. And I think institutions and the health system belongs to that, have to get a better understanding of how to re-establish trust and have to have mechanisms, you indicated it, where people do not have to have a fear of asking questions, and where the system actually encourages them to ask questions. But the fact is, in our modern Western societies, I'm not talking about any others, we are in a situation where we have neglected to really prepare our citizens for the society in which they live. They do not understand the mechanisms of representative democracy. They do not understand how a health system works. They do not understand how a financial system works. So our schools are crammed with information, but not with anything that actually prepares you to live in a society of the 21st century. And therefore, as people interested in health literacy, I think we must be part and contribute to that overall societal debate. Otherwise, we're not doing our job.
Well, thank you. I think we can thank you to all our speakers this morning and to all the questions also from online.
We also have people, I wanted to mention really quick, we have participants from Nepal and as well Dublin just joined in. So we've got a lot of different countries.
Thank you to everybody around the globe who's joined us.
Before we now go to lunch, and we will close down the live streaming in the lunch break, we would like to take a photo of the group present here, and then there will be sandwiches, and we will reconvene in quarter to one. So please line up here under the sign, and then we will have a group photo taken. So if we take the chairs away,
I think we
I
will
think
have
we
a
can
lunch.
need chairs up, and then we have people standing in the back. May I sit next to you?
Oh, and Sydney, Australia too. I was just reminded, Sydney, Australia.
please come everyone.
What's-
Meet everyone.
There is someone named, last name Zamir. Looks young though, like someone's son possibly. I do believe he said, I quote, very interesting.
Everyone who's present here.
Yes, yes.
Yeah, we got someone.
Peter, we have a seat for you.
I don't know where you want me to be. All
Well, let's put another seat here.
Is nobody else going to see?
Well, I keep getting in front of them.
You can
Yes, you do. You have a bad habit.
we get more chairs.
I didn't recognize you guys.
I'm trying to be very aware.
I know I've seen you before.
Online. This is Christine. She's getting a sign.
So we have, because we're taking group photos here and in the US next week and in Geneva, so you will have the sign of Geneva.
We learned this from you in Asia.
And perhaps you can have their logos
Can you
here.
put everyone?
No.
Put the candle. The candle.
The candle.
Still here, you hold that.
Or we put it down? No.
I can't see you.
Can you squeeze?
Okay, it's okay. Everyone.
Are we all in?
Yeah. Everyone is ready?
All in. Smile.
Let me see the candle.
Okay, and
Do you need a cheese?
This group became quiet.
IHLA.
Yeah.
IHLA.
okay.
Thank you.
Excellent. Thank you.
Tell me if it's okay.
Yeah. Lovely. Yeah, everyone.
Oh, also Vietnam, Taiwan.
Oh, that's
you gotta
wonderful.
count your
And we have
counting.
lots of people saying thank you, and they're having a good time and learning a lot.
Right, that's
Oh, we're going to lunch. You're welcome to join.
How can I send this picture to you? By email?
Sure. Yes.
So,
We're live.
technology.
We're
All right.
ready.
We're live?
Mm-hmm.
All right, well, welcome back, world. Welcome back, participants here in Geneva. All right, so again, I want to thank some of our organizers and sponsors, including the Institute for Health. The Institute, which one am I looking at? The Health Literacy Europe, Immigrant Center for Migrant Health and Disparities, University of Geneva, the IHLA, IHLA, Health Literacy Europe, UK. I get to say the National Library of Medicine, the U.S. National Library of Medicine is here, so the representative or other folks who have joined us. I really greatly appreciate your being here. We now start our afternoon session, and the focus of our afternoon session in the morning, we looked at health literacy on a global level, some focus on the migrant challenges that we are facing as a world. And this afternoon, we're going to focus on our work collaboratively, coming together internationally through the International Health Literacy Association, are bringing people together to share ideas, share resources, share approaches, communicate with each other, learn from each other to make a difference. One of the first things we'd like to do in this afternoon session is to present via video. I think we're ready to go, RV, which is an introduction to something we've been really pushing for a number of years now, which is an international, well, a journal of health literacy. If you can put that video on, RV, we're going to hear from Michael Pash-Orlow. He's at Boston University in my hometown, Boston, Massachusetts.
It's playing now. It's not playing up there. It's playing online.
Oh, we're not going to be able to see it here. All right. It's playing online, but we would
So
like
shall we
to see
go
it.
online from our mobile phones?
Yes. The
Okay.
the YouTube link is to it's a 5 minutes. I can bring it up over here.
So it's a 5-minute video, RB?
Yes.
So is it
So
playing now?
will
From
we be
Michael
able-
Pash-Orlow.
Yes, will
Do you
we
want
be
me
able
to
to play
put
it
it-
live after we hear?
Do you want me to put it up here? Let me just-
I think you're looking at it right now.
Can you see
I'm
it?
watching it right now.
Let's see if I can.
Good.
I can put on the volume here if you like, and we can.
Yeah, let's see what.
Let's see if we
But
can.
we could also project it after this, right?
Mm-hmm.
Okay.
Oh, I'm
We're
seeing.
You're
trying to
seeing it.
read
Oh,
now.
it's
Screen.
But after this, then his video comes up.
Oh, this is like about like a 30-second delay.
Mm-hmm.
As long as I'm not still.
So if I'd had
Can
all
you
these
tell- can
multimedia
you
items
explain-
beforehand, this would have been resolved.
No.
But, you know,
But what's being projected is what's here.
really,
Yeah?
no,
But the
no
30-second
Michael,
delay.
not Michael.
No? I mean, I went out through the website.
Can you explain what he's saying?
Yes, I can. Yes, but Michael did a very nice job with it, and I think we will be able to get it up. Oh,
See?
okay. We can go on with talking about the International Health Literacy Association, my presentation, and then come
There he
back
is.
to the video. Oh, he's up
No,
now.
no. You know, I should be up streaming. Yes.
Let's try. Okay.
I knew we needed to have patience with the technology.
It's doing very well.
Like I
Doing
said,
well with my patience.
yes, you are.
And with and with the technology.
Okay.
That's enough.
Let's see if it's up.
Let's try.
Yes.
Yeah, it is on.
Let me
Michael,
back
turn
up then,
yours
please.
Do you want to turn it up and hear the sound? Oh, here it is.
I backed it up. I'm starting it
I
over.
did. Oh. Okay. I'm hearing what's here and not hearing him. See, the sound is what's... Maybe you can turn off the microphone here? Because maybe people are going to hear us and see him. See.
After we begin this second session. Okay, great. All right, so if we could have my slides are up. Oh, excellent. All right. So you can go to the first slide. All right, welcome back from lunch. We will work out our technology so that you can see Michael Pash-Orlow introduce the Health Literacy Journal. So again, I'm going to introduce myself. My name is Sabrina Kurtz-Rossi. I'm an assistant professor at Tufts University School of Medicine, and I started my career from the literacy side of things. I worked for an organization when I was just doing health education. I started working for an organization called World Education, which is a literacy-based organization, and it was a literacy resource center. They work internationally in Nepal, India, doing basic literacy, combining literacy and health. My work was primarily domestic. In the U.S., it's in Rhode Island, the International Institute of Rhode Island. They have they have a resettlement program, immigrant settlement program. They also have English for speakers of other languages classes. They have family literacy, where adults are learning basic literacy while at the same time that children are learning, new immigrants. This is a program, this is me actually teaching here, where foreign trained health professionals, so one of the programs they offer, foreign trained health professionals get assistance and support to get their certifications and update their training so that they can then practice in the U.S. So folks are, working during the day, doing whatever they need to do for their jobs, to support their families, and coming then to the program at night to gain whatever skills they need to get that licensing, such as strengthening their English skills, or perhaps retraining in order to sit for various boards or what have you to get that licensing. So this is kind of an example of the work I have done, and relates to the work that we spoke about this morning. But I could never at that point have imagined that I'd be here today in Geneva talking about bringing people together for an international health literacy association, really sharing each other's experiences. So if we can go to the next slide, Arfi. So what I want to do, what my job here today, this morning, is to introduce you to this idea of an international health literacy association. It's something that myself and a number of people in this room have been kind of living and breathing, but I feel like we really need to introduce the idea every time for a while, until this really becomes much more established, and it's happening a little bit at a time. So the International Health Literacy Association, what is envisioned is that we're going to be nurturing a member-based organization, a foundation for professional development within the health literacy field. We're going to, a couple of principles is that the association is going to be broadly inclusive. And we have a very diverse field. It includes professionals from a lot of different professions. A lot of times people identify with health literacy, though, from a first professional training. So it could be clinician, it could be a teacher, it could be a policymaker, it could be within clinical practice, it could be a nurse, it could be a physical therapist. We were talking about cities. So there are a lot of, I think Alona really brought it together in terms of a lot of different folks that we want to see include within this umbrella. And it's going to be an organization, or it is an organization, that is run by and for its members. So we will decide what this organization will do and how it's going to serve its members. IHLA will serve its members and provide a platform to, these are a few of the things that over time we've identified as what's going to help us with our overall mission or vision, which is to stimulate and disseminate health literacy research and best practice worldwide. We're looking to promote health literacy continuing education and professional development. So these are kind of like three major platforms, and then of course advocate for health literacy and raise awareness worldwide. So this slide, I just wanted to make the point that that this is not just coming out of, like, we thought about this yesterday. This has been evolving over time with input from a lot of different people. Not everybody, and we still need input. But it was back in 2012, and that there was a breakfast meeting associated actually with the HARC, the research conference at that time, and Jill had this idea, and Christine, and a number of people sat around the table talking about this vision, okay, and that was a number of years ago. We then had a meeting in Wisconsin, that was adult literacy programs coming together. Okay, so and this is my experience, and I'm sure that Jill and Christine have been talking to people within their regions. The Institute of Medicine at that time started talking about health literacy, maybe in terms of an international association, kind of giving their support. 2012, 2013, 2014 and 15 for me. And I think for the people that came together from the United States, feeling like, okay, we've talked to ourselves enough. We really need to have international partners. We need to get back in touch with the folks that we were talking to. And it took a couple of years to really reach out, go back to talking to Christine and Jill and other folks. And then I met Peter. And the Asian Health Literacy Association was getting off its feet. Maybe you were 2, 3 years old at that time, maybe 3 years old. So we started to feel like, okay, we've got this collaboration going. We have a small group that's been starting to meet online, and now, more recently, we're in Geneva. So there's been a lot of these meetings, and I just named a few of them. There was also a big discussion online just this summer with the health literacy discussion list, pre-meetings at the Institute for Healthcare. If you go to the next slide. So there were a number of common themes that came up over those number of years, for the last 4 or 5 years, at all of these different, whether it was a breakfast discussion, a pre-meeting, a summit, an online discussion, a Twitter discussion. A lot of commonalities in terms of what our purpose would be: to establish a health literacy professionalism, to link research to practice, to be a credible voice, to support health literacy coalitions and communities on the ground, some of the services, publications and that type of thing, that we would be a membership organization, and that it would be a very inclusive organization, and that our structure, again, would be membership, independent, nonprofit, and that type of thing. So these were themes that came up over and over again. So again, getting input from a large number of people. If you could go to the next slide. So what I'm here now to do is to give you an update. That's kind of a little bit of background. And then, of course, this afternoon we're going to be doing a lot more discussion about these, but I'm kind of setting a bit of a foundation here. We're now doing 3 unifying, mobilizing meetings. And this is the first here in Geneva. We are then going to be at the HARC conference in Bethesda, Washington, in the US, and then we will be having another meeting just like this associated with the Asian Health Literacy Association, so in Vietnam, which is very exciting. So we're trying to start to get, actually we feel momentum happening, inclusiveness, and going going global in terms of bringing people in. Take the next update slide. We do now also have 8 active working groups at this moment. And what we want to do is we want to introduce and engage people to get involved now through these working groups. So we're going from kind of a few people talking about this, and I know IUHPE, I should have said, has been talking about global health literacy for many years, and the idea of being engaged in continued growth and being involved in this work is also very much appreciated. So these 8 active working groups are going on right now. So everybody in this room and everybody online, we introduced the website, and this is your opportunity to really get involved and for us to be a much more member-based organization, right? So if you're interested in marketing and communications, that group has already been active with our logo and getting our website going. Interested in research, planning, business planning, organizational structure, policy, education and professional development. I know Diane is taking the lead on that. Organizational structure, Rob is taking a lead on that for now. Jürgen is agreed to take the lead on policy planning. So these groups are going to come together. These groups are then going to decide what they want to do, what their work plan is going to be, and then they're going to choose a chair, and that chair is going to come together and be our steering committee. So that is how we are going to build from our members, so that we can go from a group of people that have been talking about this and really committed to making this happen and have a vision for it, to being a much broader vision and more broadly informed. Okay, if we can go to the next slide. So here is a slide of our website, which you can go to, our 3 pillars, I guess you would say. The website was being developed, and I took a screen capture of this, and the colors weren't even, like, we're now a different color, so it's improving every day. We're just getting online. If you can go to the next slide, and here is where you can actually choose to be part of one of these working groups. And if you don't really want to be on a working group, okay, you know, this is a great idea, but I've got enough going on my plate, you can just sign up for information and updates, and we'll just have your information. So that's another way just to get connected. And then if you could take to the next slide. So moving forward, I just need to recognize that the Institute for Healthcare Advancement is offering us a sponsorship and to serve as an incubator. Okay, so we're very pleased with that offer. We still need to kind of work out the details, but they're going to be sponsoring this nascent IHLA. This is an incubator idea for 2 years, potentially more if we need it, depending on the arrangement that gets worked out. It'd be nice to see other contributors, other sponsors kind of come on board. It's primarily administrative and systems support, website, administrative support, that type of thing, a database of membership. So structural. There's no governance role or in exchange for hosting us. That's not going to be their role. Really the purpose is to serve the global health literacy community. And lastly, we need to then agree on expectations and parameters for this arrangement. But it's a wonderful part of this momentum to move forward. RB, the next, I think, and one more slide. Okay, so moving forward, International Health Literacy Association next steps. And again, this is really going to be part of this discussion this afternoon. What are those next steps? We're talking about taking feedback from these 3 unifying meetings and putting them into a document and a publication, another way of kind of drawing from those who want to get involved in terms of what we're going to do and how we're going to do it. Again, those work plans, we're going to continue to do outreach to both individuals and organizations. Clearly, we have not gotten everyone involved in health literacy to be on the ground floor, and we really do want to get those folks that are really active in health literacy at this point within their regions and their countries to get in and give us that feedback and be part of this. We need to talk about an organizational structure, and Rob Logan is going to come after me and speak about a vision for a structure that will be a very inclusive structure to allow a lot of different definitions of health literacy to feel comfortable working under the same roof. We need to draft and install a constitution, really start a membership drive, and then start having our official meetings, and that is all kind of in the future that we will need to think about and discuss during these next few meetings. I think with that, there have been, I did put the slide up that had lots of agreement, right? But there hasn't been full agreement, right? There are a number of challenges that have been that we need to discuss. So how are we going to finance this over long term? How are we going to be truly inclusive and truly international? Okay, so that's another challenge. So there are definitely some challenges that we as a group will have to work out and overcome. But despite those challenges, I do feel like the momentum is now here to start moving this forward and address those challenges and make this happen so that we can make a difference in the world and take what we are doing at the local and community level and share that with each other. I think another challenge is, as we go international, is to be sure that our work remains localized. So there's working globally and there's working locally, right, within the community, and we have to maintain, both of those. So it's a big task. We have a lot of work to do, but I believe in our work, and I know the people I work with are very committed and believe in this work and believe that we can make a difference. So that is why we were so committed to this. I think with that, maybe any comments before we want to? Yes, Jill, just a couple of them, and then we'll move on to Rob.
I just wanted to say thank you for your energy and focus and keeping us all on message and talking, and it's a huge task, and it's often goes unappreciated. I just wanted to thank you because I think it's
Thank you for thanking me, and I thank you as well. No, it's a group effort. I mean, I am so pleased with this meeting. We came together, Christine, Peter and I came together, and it's like the little tiny things. We each had a few little tiny things that we were just setting up here, and I'm like, oh, this is so wonderful to be sharing this meeting to make it happen. I don't think Geneva would have happened without Peter saying, yes, it's going to happen, and I'm going like, how in the world are we going to make this happen? And Christine saying, yes, we need a website in the next 2 weeks, and I'm going like, how
do we have a website in 2 weeks?
And RV actually making that happen along with RV communication group, including Jan and Julie and other people, with Guda from Ethiopia being involved in that, and so we Tintin, I think, was also on the communications group. So
and Mario,
we need to grow these groups because these are the groups that are going to make the work happen, and the groups really need to be much more broadly representative of the world. So get those little tiny things like what's the color of the logo? We need a lot of input on that. All right, with that, I want to invite Rob Logan to come to the front.
By the way, just a comment from a U.S. colleague, Chris Trudeau, just said clap, clap.
Chris, welcome to Geneva.
Tell Chris the truth.
Well, the people in the U.S. now are awake.
It's about time.
It's about time.
Does that mean we have to start over?
No.
They would say so, I'm sure, but that's another matter.
All right, thank you, Ralph.
I'm going to stand here. Is that all right with everybody? Okay. All right. That you can see me in the. Okay, fine. Hi, everyone. Who's your idea, when you think about it, of a political leader or a visionary? Someone who clearly stands out among other people. Most people in the 21st century might say Nelson Mandela. Most people in good 21st century answer. A good 20th century answer might be Mr. Gandhi and his life and what he did. For me, the greatest ever is someone I bet a lot of you haven't heard of. He was a very little known lawyer in Virginia 230 years ago. He was 29 years old when James Madison was drafted, to write the Constitution and the Bill of Rights for the United States. Most people don't know it, but James Madison wrote both documents himself alone. Okay? Think about that as a legacy. We're 2 centuries on, okay? That document's never been changed. It has been added to. It's very hard to add to.
He was only 29?
He was 29 years old when he started.
Wow.
He was Benjamin Franklin was the most famous American writer of that era, argued that this is a 29-year-old person with the mind of a senior citizen. I changed the latter 2 words to give it more of a 21st century phrase, but he was known for his astonishing wisdom for such a young person and his clarity of thought. It astonishes me. When I was a young person and discovered how great he really was and what he was like. Okay, by the way, he did become a president. He actually was not a very good one, but that's another matter. Okay? It began to occur to me that the greatest thing that you can be asked to do if you're a professional in life is to write what becomes the constitution, ground rules, bylaws of an organization, and then see what happens after you did it. Okay, live long enough to see whether or not you did things along the right lines. 26 years ago, I was asked to write the bylaws of an organization for a group of social scientists who wanted to start a society on William Stevenson, who invented Q methodology, which is a way of measuring attitudes and beliefs, had died that year, and a number of people got together on his death, at his funeral, and I was asked, we're going to form an international organization, you write the bylaws. And at first I thought, what drudgery, and then all of a sudden it occurred to me, my God, you're James Madison, on a tiny scale. The thing I think I'm proudest of, this is not on my CV, but I think the thing I'm proudest of is 26 years later and not a word has been changed. And that organization has thrived, okay? All over the world, people involved in it, more than 250 countries now, okay? More than 5,000 members. We started out with 12. It's been a success. And I can't take credit for all those things, of course, but when I had a chance to sit down and write the bylaws for this group, take a crack at it, it occurred to me, oh, you get to be Madison again. What a good task. What a good thing to do with your time. The IHLA umbrella, let's change the next slide, please. Parapluie, is it right?
Yeah.
Good. French is a little tiny bit better than I thought. The structure is based on, let's go to the next slide, creating an umbrella organization where many diverse, heterogeneous groups, interests, and individuals are going to be welcome, that can advance their particular academic and professional interests. The bylaws are derived from a century-old mass communication academic organization where the structure has been seen as the key to creating an inclusive and harmonious, or setting inclusive, harmonious traditions among groups that are otherwise professionally adversarial and fractious. The idea that this group would last more than 60 days, okay, was almost impossible. The fact that it's lasted 108 years completely blows people away. And they argue the reason that it has is because how it was structured and run. What Christine and other people have told me since, and I've gone in to check what they've said, is actually very similar to the structure of some public health organizations around the world. There actually are parallels between how this was set up and some public health things have been set up as well. Let's go on and see the frogs. There are always lots of hoops and challenges to go through, okay, whenever you do something like this. What I'm describing to you next is the structure, okay, as it will be in the future. It is not the structure we can start with. This is the structure of a mature organization with many members, okay? And it will look something like this. We'll have different tiers of membership. Most of you will be regular members. We'll have student memberships we will have people who retire, okay? Hopefully at the beginning there won't be too many of those. We'll have affiliate members, and that's a key issue. Affiliate members are not individuals, they're organizations. So any organizations, such as all the ones that have gone through here today, they can become an organizational member and become directly involved. all the persons who are members of those organizations, if they choose to be personal members as well, that's fine. And then we'll have what we call associate members. That is so members of the public who are not engaged directly in health literacy work at all, but are interested, not students, not any of the above. It's so they join. That's how you encourage journalists to get interested in you. By encouraging them to not just to cover, but actually become associate members of an organization. You have graduated membership rates. Obviously, students are going to pay way less than regular members. Obviously, retirement, people who retired are going to pay way less. Divisions, okay? The key to an organization like this is you have divisions that are, usually a division is 40 or more people. A division can be based on somebody's professional role, nursing, let's say, nationality, UK or Korea or South Korea or wherever, academic or practitioner or other topic areas that interest people, shared decision making. If people wanted to focus on that topic, they have every right to do so, and they're encouraged to do so. Any topic you can think of, okay, that's even remotely related, as long as you can get a group of people to form together, you can have a division. If you have a smaller group, then you have an interest group, 15 people or less, okay? Excuse me, 15 people, 15 from 15 to 40, I apologize. And they're based on the same thing. Why would you do that? Because as soon as you form an interest or an interest group or a division, then you have the right to manage your own sessions, okay, within a broad umbrella of the program. You have the right to have sessions where you can present refereed research. You have the right to run sessions immediately where you talk about professional issues and panels that may or may not be research related. You get degrees of freedom to have programming within a large umbrella of the organization that are aimed at your group. If we're successful, okay, I believe there'll be 20 or 30 divisions in the future. I believe at the same time there'll always be around 10 interest groups. And yes, we'll have to go to a place with a lot of meeting rooms because guess what? They're all going to be competing each other at times during the day because they're all having concurrent sessions. We'll also have sessions that go on in the same meeting that are plenary or mini plenary where everybody gets together and listens to topics that are special or of interest. And then you have commissions. One of the things that all groups like this have learned is you have to have some method to cover issues that for some reason or other are not covered by divisions or interest groups. For example, in the organization that I put on the screen, their first commission was about women involved in the academic life as journalists, in this case, or as faculty members in mass communication. 80 years ago, that was an issue that nobody else was covered. I said 80, not 8 or 18. Okay? That commission, of course, got dissolved a long time ago because now there's essentially not a need for a specific commission on that topic. 60 years ago in the U.S., it was changed for essentially for Hispanic Americans and for African Americans, so they had a role. Commission is when you realize there's a special topic, it's not being addressed anywhere else. Those are appointed by a board of directors. My hope is, actually in a good organization, you don't have many commissions because you usually cover your bases better than that, okay? You don't really absolutely need them. Next, please. The structure. You have a council of affiliates that represents all the affiliate members. You have a council of divisions that represents all the divisional members. You have 4 elected standing committees. The membership votes to have committees and publications and outreach to members on research standards, practice and outreach to the public and to patients, and of course the group that nominates people to run and runs the elections. You have 9 people in them. The reason for 9 people, that's something that's very American. The U.S. Supreme Court, all our major decisions are decided by 9 people. Okay?
It's an odd number.
Yeah,
you need an odd number to make a decision.
Deliberate. The Supreme Court in the U.S. now is in big trouble because it's 4 to 4. The 9th person hasn't been appointed. Excuse me, that person's been appointed but hasn't been approved. That shows you the chaos that happens when you're 1 person short.
Anyhow, that's a magic number to us. It may not be a magic number to any of you, but I can tell you on the basis of things that I've written in the past, it works. Then you have committees that are appointed, okay? There are 5 of them that are recommended here. And again, they're based on what other people have done. Membership and fundraising, finance and legal, professional development, professional credentials, and it's going to be important in the history of this organization. Policy, advocacy, planning, strategic planning, and strategic plan implementation. Those are normal types of groups and committees that a mature organization has. Let's go on. You have a board of directors. That includes the president-elect, the vice president, the immediate past president. Obviously, that will take a few years to, in our case, to open up, okay? It includes the board of directors, the heads of the 4 elected standing committees. They select a representative, 1 representative by the appointed standing committees, 1 officer who's designated by the council that represents divisions, 1 officer designated by the council that represents all the affiliates, 1 officer who's designated by the commissions, whatever they are, okay? And then you have hopefully someday an executive director who's non-voting. There's usually a 12-person group. Most organizations would love to make it 9, but they can't make that work because of the way the number of people that have to be involved in this process. What are the underlying tasks? It's similar to what Sabrina had on the screen. I'm just going to say it to you this way. Okay? The tasks are to promote evidence-based health literacy research and practice, as well as the professional development of researchers and practitioners. That's the top task that needs to be done by all divisions, by all interest groups, by all commissions, by all the members of the board. You have to enhance professional standards. You have to be difficult sometimes in order for things to improve. You have to have things that are set up in place that are critical sometimes of the members of the organizations or groups. Under the guidelines and constitution and the bylaws, divisions are actually reviewed by members of the relevant standing committee every year and every 5 years. They can say the division isn't performing very well, and they can actually recommend that division be dissolved, or they can do the opposite. They could say an interest group is doing so well that they should be considered for divisional status. But you have a self-correcting standards, okay, that everyone is asked to, and the idea is, of course, to try to enhance. You need to nurture diversity, collegiality, and civility. That's something I don't think I need to discuss with any of you. I think you all recognize and understand that. In our case, we need to advance health literacy education at all levels. This is never going to work, I think, unless medical schools, schools of nursing, schools of health-related professions, and even schools that are undergraduate and even below that begin to recognize that health literacy has got to be part of their curriculum and has got to be accepted, if not actual majors in themselves. You have to advise health literacy efforts that have been done all around the world, provide an interchange, provide a point where people who are doing projects all over the world can consult with each other about. The next one is one that I guess is self-evident, but I think it needs to be said flatly. Part of this organization, in order to succeed, one of its enduring values ought to be we ought to be worried about elevating the public's health literacy regardless of where that is. And we ought to measure ourselves, our success, on the basis of whether or not we're meeting that goal ultimately over time. And finally, the last one is something that I think a lot of organizations forget about, but of course one of your purposes fundamentally is to foster the development of the organization itself, okay? Which is a very different matter than all the others on the screen. Let me anticipate a few questions and then I'll stop. Again, this is a plan for a mature organization. I propose a totally different organizational structure for IHLA as a startup and the phase prior to having an executive director. I'm not going to go into that today, but there's not as structured as what you see on the screen. Okay? It can't be that way because we don't have members that can elect others and do many of the other functions that are there. The details of how elections are done, how you sustain a membership, the oversight of divisions and the interest groups, and the other issues are actually provided in the proposed bylaws that you all will have access to. IHLA is envisioned as an academic professional development organization. It's envisioned to be an international organization. The last one is one that's going to be tricky, I think. We're going to have to file as a nonprofit corporation somewhere. And the problem with that is that some of the laws in various countries for nonprofits don't necessarily square with each other. So the result is, for example, if we incorporated, to show you an example, if we incorporated in New Zealand, that's what we decided to do. If Pfizer decided that they wanted to give funds to IHLA in the future, this is purely hypothetical, Pfizer could not take a tax deduction, okay, based on their gift. You don't want to create an organization, a nonprofit, in a place that is inimical to your functioning, fundraising, and all those sorts of things in the future. That's what you can run into, unfortunately, in the last one. I'm not an attorney. I do know people who play them on television, and I guess I could argue that some of my best friends are. But I think that we're going to have to walk a tricky legal line to make sure, however we file or whatever we do, we make sure that it's an organization that doesn't turn out to be a preemptive strike on our own success. Got to make sure that it's the laws and things are written so that it's conducive to your succeeding in other countries, and particularly your ability to raise money and your ability to engage in public policy. By the way, there's some countries in the world where if you file as a nonprofit, that means you cannot be involved in any sort of policy-related activities in others. It's against the law. So obviously we got to avoid that as well. And those are the kind of things that are difficult, and that's why this part of it I see for us is the next, essentially, hoop we got to cross. You got to figure it out through. Happy to answer anybody's questions. Thank you for your attention and time.
So questions, comments, yes.
Well, firstly, all power to you. It's a beautiful vision of an organizational structure, as you said, of a mature organization. I would like to add one more part that maybe you've been thinking about, maybe you haven't been thinking about, but with the different definitions of the different types of members or players, I would highly recommend talking about also strategic partners. Unless I missed it, it may have been there, but I apologize if I did. Because I think something like WHO, IUHPE, whatever, might not be an affiliate member, paying member of IHLA, but it would be a strategic member, a strategic partner that would want to have some kind of terms of agreement with or something like that. Something to consider.
It's something to consider. We probably, I can tell you in advance, in the groups that I know that created that, they've regretted later doing it.
Mm-hmm.
If somebody wants to be your partner, they should be an affiliate, period.
Mm-hmm. Yeah,
It'll
come up. It'll come up. That's
Oh,
right.
absolutely.
And the other thing is the associate partner, and that's going to be tricky. Someone who's not involved but is interested. I know I heard your example of this journalist.
Yeah.
I'm not sure it's going to be able to work because there's a fine line, and it might get a little bit tricky. So
Well,
just to rethink
I think you should allow the public, allow your own kids to be a member of the organization. Allow your spouse, okay?
That's for fundraising.
Yeah.
Well, what about, how does the public get involved? You know, like patient advocacy, individuals or groups?
Well, I think
non-professionals.
I think again, what you try to do is for folks who are that they can enter if they want to, okay, through two ways. They can enter through affiliate if they wish to, if they're part of an organization. They can enter as individuals, possibly, but it probably means that they would become associate members. Associate members, by the way, the rules are for associate members, they do not vote, okay, on some association details, okay? They do not vote for people who are going to be members of the board of directors, for example. So they're allowed to come, they're allowed to be involved, they're allowed to become members of the other divisions and interest groups and other sorts of things, okay? But again, there are some voting things that regular members do that associate members essentially do not participate in.
But Diane, I think you raised, an important issue. That was one of some of the pushback in some ways was like, well, aren't we already doing this work? There are a lot of organizations doing health literacy work. Is this, what is it going to be different that this organization is going to do? And then, so the question I ask then is, how do we support each other's work? What can we do to mobilize folks who come together under the umbrella of IHLA, do to support the work of hopefully people who will become affiliates or organizations that are strategic partners, as you call it, or hopefully we'd like, Rob sees it more as affiliates, but that's the idea, is that all the organizations would be affiliate members, or however we see it, but that would, how do we support each other's work?
Right. And because what you're saying is like the Asian Health Literacy Association would have to pay to be a part of this organization, is what you're saying.
That's correct. So would everybody else, okay?
Yeah, I'm just giving an example.
Yeah. So would Pfizer, okay?
Yeah.
Now remember, this is the big mature way down the line.
Yeah,
right now
we've
got working
commercial
groups.
members, what can they vote on, what they can't vote on. You're gonna encounter those questions.
Right, yes. Good. Another question or comment from the group. And this is what we're looking for. And Christine is going to be, when we have at the end of this afternoon, we're going to be recording a lot more of these kind of questions and visions and that type of thing. So this is an opportunity to collect those
They're
questions.
just first responses.
Absolutely.
And so, and again, perfectly sensible remarks and kind of things that you need to handle. Again, though, I think the folks that have survived more than a century, okay, I believe that they've survived because of their structure. People who are involved in those organizations have felt the same thing. And but again, it is tricky. It's difficult to run. It involves a lot of membership feedback, and it also means that although you get your way in terms of your individual or group interest all the time, you get to program according to your diverse needs. Okay, it means that. Okay. But it also means sometimes that the overall organization doesn't go the way that your particular area wants it to, for example. And I can think of numerous examples that happen. This other group, the larger groups that happen, it means that you're living in a place where essentially the high majority rules.
You have to be careful, I would imagine, that we don't tread on toes, that we don't make other organisations like the Asian Health Literacy and the UK Health Literacy Group feel somehow, what's the word, belittled or subsumed,
right.
That's the word, yes, swallowed up.
Yep.
We just have to tread carefully. And
Well, I think the way you do that, frankly, is you show there's a value added to being part of a larger group. Yeah. And that value added includes the website, and includes many of the things that to me are related to the website that are forthcoming.
Will the website be only accessible to members? To
No,
pay
the
members?
website of all the organizations that I described to you have a website where part of it is totally public, okay, and parts of it are only available to members, and they're given a code.
So do we have a question?
A comment, really quick,
yes.
from online. Chrissy Brennan just made the comment that engaging the community to co-design health literacy study interventions will help generate awareness and engagement with IHLA. That was her comment.
And I would also like to say, I don't think this organization is possible without the involvement of all these other organizations that are already doing health literacy work. That's the idea. That's what's going to make this organization or break it, I think. So that's why it's so important for all the folks who are actually doing health literacy now, which is not that many of us really at this moment, to come together, because ultimately we want a lot more people to be doing health literacy, right?
Then the membership question is the real key.
So the question is, so that's
It's
something to
really
ask. I
gonna
mean,
be critical.
Is it
So it's going to be a membership organization, a paying membership, and that's the only way to get involved? It's going to have to get, you're going to have to be very determined to keep that policy going.
Well, one proposal, at least to start up, and I mean, again, is that this is going to be a free organization for at least the first year. Is that people can sign up and and we'll figure out the membership. I'm telling you, we haven't even thought that far in terms of costs and finances. That's a whole other question. So, Rob is a future thinker. I'm a today thinker. Let's get this. Thank you, Rob. So I'm going to now again announce Michael Pastorolo introducing the Health Literacy Journal. I can't tell you how many phone calls. I asked him, am I really bothering you with all my texts? And he said to me, don't you have more important things to worry about than whether I'm going to, get my video? And I thought, yeah, this video, is it going to happen? Is it not going to happen? Anyway, it's going to happen.
Could you turn the lights down, please?
All right.
Hi, this is Michael Pastorolo sending you a video from Boston. I'm sorry to not be there with you in person. I just couldn't make it. Very excited about the start of the conference.
Oh, shit.
Things I've been involved with and things that I really hope will be interlaced with the activities of the IHLA. First thing is the Health Literacy Annual Research Conference that I've been to see. I'm looking forward to seeing as many of you who are able.
They can see it up there.
HARC has emerged as a pretty good representation of health literacy research, and I hope we can continue to cultivate this field and to promote it, and to be a venue for professional development in this field. HARC's focus is on research, and there's still lots and lots of work to be done. I can also tell you, with respect to HARC, that we've already arranged for HARC 9 in 2017. In 2017, HARC will be done concurrently with the International Conference for Communication in Healthcare. That's a conference that alternates between Europe and the United States year to year. Just recently it was in Heidelberg. It was a fabulous meeting. And next year it will be in Baltimore concurrently with HARC. I'm going to be the overall chairperson for the joint meeting, and I really look forward to welcome you to come to Baltimore 2017 for the joint ICCH and HARC conference. I can tell you that we've already arranged that members of the International Health Literacy Association will get the member rate for participating at that conference, which is a nice benefit. And I hope people can come and really present fabulous health literacy research at that meeting. Please let me know if you have any questions or if you'd like to be involved. I also, another project that I've been working on is to launch a new journal, the Journal of Health Literacy. This journal is an activity between the Institute for Healthcare Advancement and the health literacy community. I'm the I'm the editor-in-chief for this new journal, and really we're looking to promote the field and to be a home for health literacy research and practice. This is a very important point. I don't want this journal to just sit on the shelf and to have no impact. We really want this journal to have a forceful impact in improving healthcare and public health. And what needs to be done to do that is to not just to present research for research's sake, but also to have a significant focus on research to practice and implementation, dissemination. So we will be doing that, and I really hope that you can join us in this effort and help figure out how to create a vibrant journal, a home for health literacy research and practice, and to have it be a venue, a platform through which we can really improve this field and improve the relevance and impact that this field can have on healthcare and public health. Last thing I want to mention and to bring up is that I've also been working as serving with the IHLA in the working group on research. This is an emerging concept. I'm not sure exactly what this working group will be tasked with doing. I think it really will depend on us and what we want it to do. So if you would like to be involved in this, please let me know. And we can figure out together how we will make this a successful activity for the association. So those are the three things I wanted to bring to you. Sorry I'm not there in person. The research meeting, the journal, and the health literacy working group. So as a final parting comment, just before I sign off, I want to say that we're in a very tumultuous time in the United States and North America, in the United States in particular, with our elections coming up. And so I hope that even if you can't join me at HARC this year, that you will overall next year help make HARC great again, and that I think that together we can make the IHLA a great association and a fabulous success. All the best. Be well.
I think you should say keep HARC great.
Keep HARC great.
Well, that's what we've been
Not
trying.
like again.
This is what we've been trying to say in the U.S. for a number of months now. But anyway, I thank you so much, Michael, for doing that. Thank you, group here in Geneva, for your patience. Actually, the sound was quite good online, so we're going to be able to. We have the online version of today recorded, so we will. The folks all over the world heard that not loud and clear. We also heard it. So let me now. So again, thank you, Michael, and thank you. I'd like to ask Peter now to come up to the front. I think the Asian Health Literacy Association is an organization that we can learn from as we expand.
Well, I have to start now because Asia is going to sleep very soon.
Yes.
And a few years ago, when Herman Brown went to Taipei, I was sitting next to him, and he's talking about health literacy. The first time these two terms mixed together to me, I'm in public health for 30 years, and I look at the website, see, wow, there's been quite a lot of activity in North America and Canada, Australia, Europe. Asia is very in dark, but actually there have been quite a few very active scientists involved in Japan, Korea, Australia, Malaysia, and Taiwan. But on the other hand, like some of the countries I'm going to mention, nothing has been mentioned. Doesn't mean they are not paying attention to it, but just because something was, and I was very curious that, we should do something. I mean, we are here, right? We are there. So I'm going to talk a little bit about region, but also trying to mix my my thought on health literacy through the years working with Christian, Diane, and Sabrina or Jürgen. That we have this definition of health for many years. Okay, but what does that mean? Okay, there is a definition here, but we want to, and they say that health right is very important, right? And the more we talk, the health right. But health literacy, how can that be part of our health right? And the right to access, to improve, and to learn, and to secure. I mean, if that is a property, I want to secure. If I buy a car, I want to property. I want to secure and want to make it running as I expect. Yeah, look here. All right. So I'm thinking there must be a way to literate the health, to make health really useful, understandable, not by a healthcare profession, but by everyone. You know, they're supposed to own it. And we start to use the survey, HLEUQ, in 2013, and on 1,700 Taiwanese women. Okay, particularly mention about this study. And they are like Europe, some are good, some are 50 or not so good. We have been universal health coverage for 15 years by the time. And we spend a lot of time, we are one of the country having 15 times clinical visit every year for every individual. It's next to Korea, Japan, we frequent visitor, and they are waiting, and they spend a lot of time, a lot of resources there, but what do they get? Okay, our life expectancy is not as good as we should be. That's right. So we look at age, certainly important, and this is the diagram, general health literacy, healthcare, health literacy, disease prevention, health promotion, and age really putting things down. But we find that something may be able to modify that if the women really spend time to watching television program. By the time we don't ask them how much time they are online, because this is most of the women, and really social programs, intervention you mentioned, really helping. We do not know what did they really get by spending time on television. And also if they are involved in more community activities, if they receive some training when they were young, really helping these women when they get old, their health literacy can be secure. Means there are something we can do to these women. All right, next slide. Okay, and we spread these words around in Asia, in Indonesia, and we send them actually UQ, and they provide an answer. And one day I start to visit. All right, who are we talking about? I mean, they answer the question, right? And we see the scares, but who are they? And I asked my students, many of them said, where did you find these women and survey? Okay, they are in the rice field. They are in the, banana yard, okay? Do they really understand what we are asking? In many of the mega metropolitan cities in Asia, in Jakarta, millions of motorcycle women, see, there was day and night like that. So I would say, well, the survey is so important, but they are more than survey. There must be something inside. We have to find it. So my interest is to go to different countries, Thailand, to see what do they see about health literacy. And Christian has the dictionary, the topology. What do they say? Even today, 3 years after our discussion with Bina, there's the vice minister say, we are thinking, what does that mean, health literacy? We have no definition. There's no translation in Vietnamese language. So I think there's a lot more to do. And if we look at healthcare service activity in Asia, I don't want to mention about which country they are. It's very quite popular. It's not only one country. See all the young girls, they are on IV injection. Next slide. And there are some healthy girls, they are going to study high school. They are on IV injection purposely.
For what?
Well, to keep awake all the evening to study. There's nothing prohibited them doing that.
What's in the drip?
Well, it's a normal saline glucose. Yeah, next slide. And there was some of the, I'm particularly showing the women, they are hospitalized, but in very peculiar setting. Okay, and you see a lot of this. What do we, healthcare provider, when we talk about health literacy, what do we mean to them? I mean, what health mean to them is life and death, right? But it's more than that. What do they get? And not only women, men. And so we did a 6 country study, and this is number. And we try to go to different parts. Kazakhstan, Myanmar, Vietnam, actually it's in Haiphong area, and Malaysia, Indonesia, Thailand. Next slide. So so we put the data. Certainly it's different survey, like you have very representative. We do not. We ask them to go to different districts, and but you see that from here, Japan, Indonesia, Myanmar, Kazakhstan, Vietnam, Taiwan, and in general Asia, very wide, big diversity. Japan has very interesting study on the senior, and they find very low health literacy because over healthcare. You know, they are too much healthcare to these old people, and they don't know what's going on around and provide to them. Next slide. All right, so we find it's a problem, you know, not a problem, the issue that how to improve the health of the individuals and the public. So 2 years ago, we have this one. I see many of you were with us, and we with Shamanov, the guy, he was from Kazan. He mentioned about primary health care, 1978. He was with us. I mean, people are interested in health literacy and should be revived and should be moving ahead. So that was the first early meeting in Taipei, in our university. But we see that when we do that, we know there's quite a lot of active member already out there. So. Okay, so we have much bigger every year, and the trees, all the institution, we go by institution. We don't ask individual member. We say, okay, you are the department, you're the school, you're the college, and so the trees grow more and more and more.
There's stars in the sky.
The star. And we are very, very generous. You know, the membership is very low. 1 year, $100 or 150 for a little bit better economy, resources-wise, better country. So we are not really using the membership. Actually, but the membership is required when they go to vote. For example, we vote where we're going to have the next meeting, then that they count. Next slide. So, and 1.5 years ago, we were happy to have the first Geneva Health Forum. And this is WHO, so we want to see what WHO think about that. That many of ICMSD members were with us to helping the IHLA. Okay, and last year, so we will have 3 rounds, the IHLA meeting in different part of Taiwan, and we decided we would move out of Taiwan and to very, very different part of Asia. We were lucky to have Vietnam, so that was the meeting, and Onsa and the Dean was there, and the Jurgen. So, well, we have a little bit entertainment besides the scientific. I don't know about heart. I mean, more mentally, right? Enrichment. Okay, next slide, please. All right, so that was the last meeting, and we tried to have a sign that IHLA was with hand sign with particular meaning. Next slide. So, and I was able to see IHLA being active in Indonesia, particularly they run in Mita. It's not Jakarta, it's small suburb. Semarang was really active, and the director of health, he said that, yes, health literacy will be our agenda. Disregard what Jakarta is thinking. You know, Semarang wanted to, okay, that's great. And Vietnam is going to on November, but in September already, Ho Chi Minh City, there's a district hospital already organized the health literacy workshop. So even in North and South Vietnam, they are competing. Okay. Now, so I want to because I'm very much influenced by Jürgen that how we going to do, where are the platforms to do it, and I saw the hospital has to be done, and I have a rationale to say that. Okay, it's actually in every when people really in at risk of the health or their life, they really need a lot. They reason a lot, and based on what they probably didn't have good health literacy, or there's no environment, or the family member was not supported. But sooner or later, when they was in that crisis, and I learned this in the last 3 months when I was helping my mom overcome her cancer to save her own life. So I see this is really important that health literacy go to the help the patient to know the very health, and also to help the healthcare professions, because most of the time, provider they didn't know what does that mean when they did some prescription, right? And so this is the situation that in many parts of the world, and there was hours and crisis, or 3 days, or 1 week in ICU. There's a lot of tremendous amount of information come to that decision making. Usually at the time, patient, the family, the community, they didn't know. But now we have a Facebook. We set up a Facebook to discuss my mom's disease. My brother has a big fan. About usually 1,000 people follow up her news because that Facebook. And we have to face that challenge, right? We're between us. There was a lot more discussion on disease. Next slide. And okay, certainly we would not like the hospital to be like the refugee camps. Really, but that happened in many parts of the world. And there was a problem. Next slide. So I see the hospital. I'm thinking the hospital should, at least as a good part of the life experience, to like a classroom. Every time they visit receive a healthcare service, and it should be like a classroom. They enjoy it, and they can use it. And because before in the classroom, the curriculum, the textbook, they read it, they pass the exam, but they don't know it. But now, back to the real life, they went through this process. The family, the patient itself, if we can offer that opportunity as a classroom. And also, this is my mom, and she has a hearing impairment. So the doctor was instructed to write down as a way of communication. And usually doctors do not write, they write prescription, right? They write to the pharmacist or the laboratory test to do something. They don't write, let the patient understand what they are doing. But I see there was a way that this can be done. And I think that, so health literacy is individual business, not only classroom. It's every individual, because every patient needs different variety of the complexity of the health literacy. Okay, so I see the hospital purposely learn from the patient, family, and their partners, and from teamwork through multidisciplinary. And how the health literary hospital could be in the future model, which is like the Jürgen has been initiated. All right, this is the last one. I was happening to read Microsoft is crowding, health crowding. And actually, one of the richest men in China, Ma Yun, he would say that he was integrating 200 hospitals in 2 months about the registration, about the prescription system. So we are having problem about this healthcare finance sustainability, actually, some of the country. And I argue that the health literacy should be part of that system, that we can provide, we empower the patient, empower the families, but also on the other hand, we transform the way healthcare service has been delivered to the patient. And we can take advantage of this IT technology, the website. So I see the health literacy should be for all the people, but on the other hand, with people-centered. So this is two very big drive. We don't have adequate healthcare profession, as I learned. We didn't have adequate, and we're going too far behind. And how can we do that? Increase the price? No, it doesn't help. So I think health literacy is one way to help the health system in the future. And so I appreciate that there was an occasion we can work together. I told my students, this is a revolution. Don't say that openly. Yeah? You couldn't say revolution, particularly in the medical community. You don't say that. But health literacy may help that reform or revitalize, and that the patient, family, and the physician, healthcare provider enjoy the service much better. Thank you.
Questions?
No one wastes the 2 minutes.
You let us turn the light on behind you. There we go. Peter, questions or comments for Peter before I jump in? Let someone else go. Do you have a Okay.
Maybe me.
Okay, and I do. I have
yeah,
a couple. And
we've been very impressed to see how the group that you put together, your Asian Health Literacy Consortium, how it grew out now to a big association, and using the European Health Literacy Questionnaire, adapting it where it was necessary, and then during the last conferences that have been in Taiwan, and now we go to Vietnam, results have been coming in, and also through a lot of young researchers. So we were also kind of a mentoring process and creating awareness for everyone, and we were also, of course, from our side, curious, will it work in an Asian setting? And they tell us it's working, and where it's not working, they are making adaptations. So that's why we can now make the league table. I know some of the samples aren't exactly the same, but we can start, like Ilona Kikus was saying, compare. Now we can start to compare not only within Europe, but also now internationally, and that is, thank you to Peter.
Oh yes, yes,
Please, thank you very much, Peter, for bringing us in to this arena, because our university, our faculty is really impressed and would like to join. And then I know that you have inspiration and also ambitious for something. So as members of the association, we would like to contribute. So what is the kind of the aims or the contribution of the members in Asia for this association that you expected for?
Well, it's quite important because health literacy shouldn't be just an ivory tower discussion subject. It should be everywhere. It should, from the like public has to go to community, go to hospital, go to individuals, go to website. We are still not in that, because I see the Asian healthcare system. Certainly, I'm not an expert in this area, but we brought in the technology, we brought in the IT, we brought in the scope, MRI, CT, but we have not, we do not have resources to explain to the patient and the public what is that. So is the resources is very centralized in limited hands. So I see health literacy is one way, and I know that if we go to Vietnam, you happen to visit some hospital, there are 3 patients on the same bed. 3 patients on the same bed. So it's still like that in the national hospital. So what does that mean? The health literacy to this individual. I like the Ilona mentioned about democratization. It is part of the process that people understand what they can have and they can enjoy. Yes.
I'm sorry. When you're done, there's a question from online. I always wonder why information from traditional and alternative practitioners, those are in quotes by the way, are more accepted and followed in Asia. And then the second part of the question is, will culture always trump health literacy?
You want to answer that question?
If you need help on the second one, I'll help you.
No, the first one I see that traditional medicine or whatever, they have been tradition, means they have been tradition in the culture, in the society. It's easy to talk about it, but it's very difficult to talk about the image of MRI with the new cancer, some new DNA mutation. It's not in the culture. Maybe more in Europe, American, but not in the culture because the short. And therefore, TCM has their advantage because they use the friend language, easy friend language, and that make things work.
I think it's also important to say that health literacy, as I see it in its purest form, is culturally appropriate. I mean, the question is really interesting because it assumes there's something that's superimposed above culture, and I think we have to really clarify what we think about that. So thank whoever that is about that question. But if we're going to be doing a good job with health literacy, we're very sensitive to cultures, and we're bridging so that information and tools and skills are culturally acceptable. So think we have to be careful, not to override what cultures are accepting. And I think it's also important to mention that because of all of your work, some of the young researchers and the young scholars have launched some really impressive initiatives. For example, in Manipal, the Center for Health Literacy that was launched this year because of all of your initiative. There's really a lot of satellite work being done, and it's really important to acknowledge that.
So I have a comment, and then we have another question. So Peter, you talked about your mother, and my father-in-law went through a similar situation, and here, I have a very highly educated family, and my husband and his family had a very hard time managing and understanding the healthcare system, right? Despite all that education, being an overeducated family, I could even say. So I think that's something about health literacy that it really affects all of us, right? It affects everyone when they interact with healthcare, because it's a difficult situation, it's hard to understand, it's something totally new, right? Literacy is contextual. So if you haven't had that experience before, how in the world would you have the vocabulary or the understanding? And a lot of times we make a lot of assumptions. So that it resonates for so many people. And what I saw is in Asia, you're introducing this concept of health literacy to folks, and people are immediately getting it and coming on board. A lot of new people are coming into the field just every year. 4 years ago, 3 years ago, 2 years ago, more and more people coming into this, a lot of new professionals engaged in this work. So my question is, well, how do we really get folks up to speed, right, of what is health literacy? What have we learned so far? So I thank you for including me in your meetings, and just another reason why I think that this association is so needed. And just lastly, in terms of the culture as well, I think it's really a matter of what makes health literacy different. It's culture, language, and literacy. It is all entwined. And I think your comment was possibly related to culture as well, but go ahead.
Yes, it's related to this. I will short. I think, I strongly believe that traditional medicine and traditional culture can be the starting point for literacy and for teaching science, because it is related to the culture, but it is necessary to select the things, because some of the things are very good, in fact are very useful, and others less. Now, if there is this selection of what are the subjects that can be used, I did this in Africa, for example, and we analyzed a lot of traditional cultures, and they can be very useful, but it is necessary to transform them in some scientific value, scientific evaluation, because it's not can be dangerous. But I suppose that in Asia it should be very, very important, of course.
Can I add?
Yes, please.
Yeah. Thank you, sis. I think because I think there are some gaps between the people and what we call modern medicine or Western medicine. See, as an Asian, because I wasn't as like Oriental or Eastern, so for the people, it's very hard to understand what the doctor said. There are some technical terms, and they thought that they are different. So whatever in the traditional medicine or alternative is very easy for them to understand and what they perceive, and it's more likely to be culturally, traditionally accepted or adapt to their daily life. That's what they perceive. So when we teach, we talk about modern medicine or Western medicine and traditional or like kind of Oriental or whatever. Right now we normally call alternative medicine, and the Thai just thought that we don't need to select, we should complement. So we introduce the term complementary medicine in order to harmonize and make people healthier by both. So there is some gap, and the trust as well. Sometimes as professionals like me talk to the people, they may not really kind of understand or really think that it's going to work, but they talk among themselves or the folk, how you call that one, the traditional healer. They are more likely to trust because they are the ordinary people that's horizontally like the same, not vertically to what we see.
But one element I see, I think there is a big difference, certainly including the cultural varieties, because the disease, I mean, in Oriental, is a family issue. It's, so when doctor is not just telling the patient, it's telling the family. And because health literacy is very important for individuals, they are sick, they don't learn too much, so they need a lot of assistance from their surroundings. So I see this health literacy for individual, for the family, for community, and we are in this new era of the social media, and that could be another element of the study in the future.
Thank you, Peter. Oh, do you have one last?
Yes, Raul. We have something very, very short. This can be a good example. Maybe it's going in Asia or in other countries. In Mali, there are medical doctors that are organizing agreement with traditional healers. And if the traditional healer cannot deal with the diseases of the problem, he takes the patient and go with him or her to the hospital. And there are real respect each other, medical doctors and traditional healers. But traditional healer needs to know what are their limits. Medical doctors also need to know what are the cultural limits.
So the idea, and there is a strong, there's a growing research base for the idea of a community health worker model where you have community, natural healer. I think that there's a big umbrella that can incorporate a lot of people that do that kind of work in the community. So thank you for your comment. I really want to move us on to the next, Christine. So come up here, Christine. This is our final formal presentation. Christine.
Yeah, thank you. I know it has been a very long day, and I want to start this final presentation with a small story. So Arnie, will you click the next one? It's a fable by John Potter from Howard. It's about Fred the penguin. And Fred the penguin, he lives on an iceberg with his friends and his family and his colony. You see him here, he's walking around feeling quite safe, happy in his own world. But then one day he realizes there is a crack in the iceberg. And he observes this while he's walking around. And he's a bit unsure, what should I do about it? So he decides, oh, I better go to the leader of the colony, and she is saying, well, yeah, maybe I should also go and look at it. And they are looking at it, and they see, well, it does not look good for their colony if this crack is there and it will develop. So they go back to their council, and their council said, well, I don't trust it, you don't have any data, what is this, a crack? I've never seen a crack. And the leader, she's kind of supporting Fred because she has also seen it, but she doesn't know exactly how they can convince their council in the colony to do something about the crack. So they had many ideas on how now to test if this was the truth, and one of the ideas that came up was that someone had found a bottle in the sea, and they decided to fill the water into the bottle and leave it overnight, and if it had turned into ice, it would have cracked the bottle. And they were like, we will wait and see, it's not wrong. And then next morning, indeed, the bottle has cracked. So suddenly the concerns start to spread in the council, and they think, what should we do about it? This is our home, this is our society, it's under threat, what can we do? And one day they see a seagull in the sky, and they say, that seagull is not always sleeping here, he's always going somewhere else. Maybe that could be an idea that we consider. So in the council and Fred, they asked some of their people to swim out in the sea and see if there were indeed other icebergs that could be of interesting for them. And the thing happened that eventually they got people mobilized. The young people also understood that this is something that matters for the colony. And they find, take the next one.
sorry.
They did indeed find another iceberg here to stay on. And they moved and they lived happily ever after. So, what does it have to do with health literacy? Well, when we came into this story, we realized that we did see something. Health literacy was defined by the European group, by many other groups. We have definitions. Next one. It has also been described in many different models. There is something, there is a phenomenon called health literacy. It's also been measured by many different people. So there's something going on. And indeed, we also see that there are cracks. It's a challenge, it's a problem for many, many societies. So what does it leave us with? A big concern. So I feel like Fred the Penguin saying, oh, we need to do something going all over the world, because we have some, no matter which tool we have used, the way we're describing it, the experiences that you have told today, personal stories, we all see there is an issue with health literacy. So our iceberg is melting as we stand today, and we have to recognize that. And we know that we need to bridge the gap of health literacy because it's evident, it's measurable, it's feasible. We heard that from Joanne today. You were telling us we can do something about it. And it's for the public good. It's even for an ethical imperative to do something. So we need to develop health literate societies. We need to move from one iceberg to the other. And one idea that has been mentioned again and again today is what this Danish of origin, Søren Kierkegaard, a Danish philosopher, he says 200 years ago, if one is truly to succeed in leading a person to a specific place, one must first and foremost take care to find him where he is and begin there. I think that was important what Peter also showed and Joanne this day, going out in communities, taking footage, trying to understand what is going on in people's mind and how can we support how they develop health literacy. We've seen this slide again and again in different forms. I was always very triggered by it because I think this was designed in the first wave of health literacy where it was very much focused on people skills. So it says people skills and competency should match the complexity of health systems. I want to turn it around. I think that is our next challenge, especially for this association. We need to strengthen the competences and the skills of the systems and organizations to meet people's complexity. So that is our mission. And by doing this personalized care, health literacy will be a key to empowerment and equity and sustainability. For a long time, our health systems and social systems have been working on a one-size-fits-all model. We all get a box, we all get the same thing, all the same education even. But what we not all will get the apples, not all will be able to pick the fruits. If we can do like they do with the other three, look at each person's individual needs, each society's individual needs, each community's individual needs, give them the boxes they need to harvest, then I think we have really achieved our mission. So we need the investment from all different partners. We've had a lot of good contributions today on that. The health literacy leadership is needed. The association is one step towards that, having a global leader supporting all the initiatives around the world. We need health literacy strategies. We need health literate systems and organizations, communities, and we need health literate people. One example I want to show is from Scotland. Our colleagues there have developed a wonderful health literacy strategy called Making It Easy. Their aim is to highlight the hidden problem. So they have realized that there are cracks in the systems as it works now. And they have explained in a very easy, simple, plain language how low health literacy leads to poor health outcomes. and they call for action. They try to involve all the people in their national health systems, and they set out an ambition for all in Scotland to have the confidence, knowledge, understanding and skills we need to live well with any health condition that we have. So it means who you are, you have to have that confidence, knowledge to be able to act. And they have some specific political actions laid out. There is a political commitment in Scotland, and this could serve as a template for other countries or other societies to follow. So we have now a new global health literacy agenda we would like to try to influence. Our new International Health Literacy Association. We're trying to uniting in the International Health Literacy Association to set up the global agenda, mobilizing the community and making a difference through research, policy, education and practice. We face the challenge and we can make the change.
Okay, let's see. Questions or comments for Christine about penguins?
Can I make a historical comment?
Yes.
This is a lovely presentation. Kierkegaard's quote, this shows how old I am. 15 years ago, maybe longer, I used that quote to teach physicians about empowerment. And here it comes again. It just shows how health literacy and empowerment go hand in hand. It just brings it home again.
So I think we can, with all this food for thoughts, our idea was to ask you now to provide us with your hopes and dreams for the association. And I did ask Ilona Kickbush before she left, so she wrote it down. And we can put it here on the wall. So if you take a piece of paper and write down
And can
a wish.
people online write their
And
hopes
online,
and
the
they can
online,
post
the
that
next
online?
one,
Yep.
they can write
Yes,
their,
posting there.
their wish, and we will collect it, and you will do the same in the US next week and in Vietnam, and by having your input we can move on with the global health literacy agenda.
What about you, Mr. Wizard?
The wizard. The wizard.
The wizard's resting.
The wizard
For this
is
Health
resting
Literacy
for a moment.
Association, for global collaboration around health.
You need a yellow brick road.
I'm ready to go home. I'm ready to go home.
We're going to do the same thing.
Voting in Chicago.
We're asking online to send in
Yep.
their hopes and dreams
Yes, yes.
for this health literacy collaboration globally, Health Literacy Association.
Leave some
We're
of
going to do the
people
same thing in Hart.
comment.
Sure,
next
we will
week.
read them up.
Yeah.
And then also at the Asian Health Literacy Association meeting in November. And we'll bring all these together,
It's
compile them.
we have a very chatty group online. I
Oh,
will say
yeah.
that. They're all talking to each other right now as they listen to us. So that's good.
And America's waking up. See, there you
See,
go.
they're finally waking up. Excellent. Very good.
That makes sense. It's around 9:30 in the morning. Right?
Mm-hmm.
People have their morning coffee.
So again, for folks who are viewing from the outside, we're wrapping up and collecting hopes and dreams for an International Health Literacy Association, an international collaboration around health literacy. You can send your comments in. We will collect them. We'll also collect from the group here, as well as from Park and Asia next month.
Question.
Yes.
Because this October is Health Literacy Month.
This is Health Literacy
Okay.
Month.
Are you
Yes.
thinking of as a leader of this? We are the leader. Health Literacy Day or something in October? Or
Well, how appropriate for us to have this meeting in October. This was our Health Literacy Month activity,
Yes.
which we need to write about and let folks know about it. October Health Literacy
Well,
Month.
should I put yours up? Do you have it?
Did you write one?
I presented it, so.
Oh, you presented it. We need to capture.
Umbrella. Umbrella. I got that word from you.
Harvey, do we have some comments coming in?
Mm-hmm. We certainly do.
You want to share some of those with us?
Yes, one is multi-level, multidisciplinary approach should be a great way to develop health literate organizations. Another one from our American colleague Chris Trudeau, create a regulatory framework / actionable plan that countries can use to help build health literate practices within their country. That's what we got thus far.
Okay. Well, we, as an example, in the U.S., we have the Health Literacy Action Plan, which is a good a model.
Right.
Be interesting to see how other countries come up with their models.
Another comment that just came in, for an association that strives to bring results of health literacy research to clinical practice.
the day. We've had so much food for thought, and I think we're also now a bit boosted.
As well.
And lots of food here in
Lots of
Geneva.
food.
I hope everyone else online has enjoyed the day. Basically, we started this morning with Jürgen Pelikan showing how we can benchline health literacy and compare across countries, and he was telling how in the German-speaking community initiatives have been made at national level and locally, and now it's part of 10 national goals in Austria, and in Switzerland they are setting up now also new networks. We heard how local action can make a big difference, and how training of professionals is actually a very positive thing, and it makes a great impact, and then also how children can learn through practicing and role plays. We heard about migrant health and the major challenge we all are up against in these times that we're living in. We got the recommendation not to be modest, and in our room here and online I think we all agree how health literacy is so important, but we now need to tell and share with the world as well. And Ilona linked up to many different alliances, many different partnerships, and she also made the bridge to sustainable development goals, which I think will highly influence the global health agenda in the future. We heard that there are many different types of literacies we should consider, and especially digital health literacy and research and scientific literacies. And Diane was sharing all concrete examples from babies being smart until elderly. So it's also, we need to look at health literacy from a life course perspective. RE was urging us to look at equity, and that again was a topic that came up again and again, linking it to citizenship and democratization and empowerment. And in the end, this afternoon, we were trying to outline the ideas for our organization. We're starting up today, next week in the US, and next month in Vietnam, and hopefully by mobilizing our health literacy community with the ideas that we got today, and Rob Logan's very clear outline for a very long way into the future, starting more from the top with the structure instead of letting it grow organic, dynamic from the bottom. We do have the ambition to be a major player in the discussions on global health. That's why we have invited Logan to give your input, and thank you so much for that. It was a really inspiring talk. I hope everyone has enjoyed the day. We certainly have. Peter and Sabrina and I and all the people who made it happen under tight time pressure, and who thought years ago, actually in your timeline we had a breakfast meeting in Southampton in the UK, which we should add in the morning.
And the dinner at Heart.
And dinner at Heart, so we can all think back, how did this idea come to heart? And I recall one day Sabrina was sending me an email, should I go to the European conference or the Asian conference? And I said, we better go to the Asian conference. And I think actually
Peter.
And now we are here. So thank you so much, everyone. I know Peter and Sabrina, if you want to add.
I just want to thank everyone again for coming. I mean, I also recognize Peter and Christine. It is the mobilization, the energy is wonderful, and we need to grow that energy and bring in more folks. But I'm so pleased. So thank you all very much.
I appreciate that occasion, because we've been growing as a health literacy body around the world. With many years, I was sitting in Maastricht with Christine, and it's 4 years already. And now we have Sabrina and I am Jürgen. So I see it as a good success. And I will spread this word to our friend in Asia, and keep on going and to join you.
So we will do our best.
for all those who joined us online.
Safe travels for all present and all online.
Very good.
So you are in there? All right, yeah, we know. See you very soon. All right.